and we go home not the only way we came into this room, but we go home well packaged. Without much ado, I want to call on our first presenter of this morning. When you look at our program, our first presentation is issues affecting service delivery from the local government perspective. And our presenter is none other than the DHO, Dr. Baizi Newton, the DHO Chiboga. If you can come up, Dr. Newton, if you are available, and you are most welcome. Thank you so much.
Okay, Honorable Minister, all protocol observed. So I've been introduced. I'm Dr. Bahiz Archibald, DHO Chiboga, and I'm going to speak on behalf of the District Health Officers of Uganda as the Publicity Secretary. So we're going to look at the issues affecting service delivery from the local government perspective, and we shall shall base on the building blocks. So our first issue is about governance, leadership, and management. Obviously, we appreciate of the already existing structures, both administrative, political, and technical. These help in facilitating performance. We appreciate the enabling environment, the availability of policies, guidelines, and SOPs, and support by the IPs. But we have challenges. Challenge number one is the number of districts continue to operate without substantive district health officers and the assistant district health officers. We are below 60%, and this is not right for a good system. A continued concern about coordination between Ministry of Health and local governments. Who is responsible for the district health officers at the Ministry of Health? It's a big question. Where do we belong? Do we belong to the Ministry of Health? Do we belong to Ministry of Local Government? Those are issues that we need to find answers. The district's not involved in bottom-up planning and budgeting. This one used to happen many years ago. Today, you are only given IPFs even when you are midway planning phase. So what can we do? Regional referral hospital supervisory role to lower local governments. What is the responsibility of the regional referral hospital? Is there a framework? Is there a guiding policy? That remains a challenge. Then we have lots of bureaucracies. This one is known to all of us, and the red tape, and sometimes political interference. The other pillar is human resources for health. We appreciate the new structure in place pending implementation. We appreciate the trained technical staff available at all levels despite inadequacy. We appreciate the government and IP support for capacity building, the availability of other structures like VHTs and other supporting government structures. But we have challenges. One, the increasing population, which put the current staffing structure at strain because they are really not enough, and all of us know this. The issue of organized absenteeism. is something that is very critical, and everybody who spoke yesterday alluded to it. Lack of wage to recruit to fill the vacancies that exist. Even when we are happy and a bit excited about the new structure, but we are not 100% of the existing structure. And most importantly, the critical cadres. And then there is a ban on recruitment. So that is a very big challenge. We have several schemes of service not yet implemented. Others I know, they are upcoming. And we have inadequate human resource planning and development across board. Then health facility levels have their human resources for health revised, but it's very unfortunate that up to today, we have not seen a sample of the district health officer's office structure, human resource structure, not yet in place. So we don't know where we belong. Obviously, when I ask the question, where are we? There should be a discussion on centralization of certain cadres, importantly, U2 and above. You would have the ADHOs and DHOs centralized, probably would move forward. The other unfortunate bit, which is a big challenging, is that you are managing PHC. As a manager of PHC, you are paid outside PHC. We are supposed to be paid on PHC, actually unconditional grant. So if the district has no funds, the entire DHO's office is off. I don't want to explain more on that. And of course, we also have irregularities of non-conformance of performance management. Find every manager doing his or her own thing. I was very happy yesterday and days ago, weeks ago, the Director General communicated that they were preparing performance plans for the different facility, district and regional managers. But I hope we have also aligned and harmonized with the local government. And then also the question is, can we make managers? That's another issue. Financing, we appreciate the timely release of funds. We appreciate the result-based financing for Health Center 2, Health Center 3 and Health Center 4. The guidelines available for financial management, the support from the center on financial management. But of course, we have challenges. One, many unfunded priorities. This one is known to all of us. Okay? DHO's office inadequately funded amidst a variety of activities that come from time to time. You know, when actually a DHO's job is you just have to sacrifice. It is just a work of sacrifice. Okay? There are many assumptions. There are many assumptions that we have. Maybe you have IPs, those are just assumptions. You need to be in the seat to know what happened. Good thing, most staff at the Ministry of Health who are directors and commissioners have been DHOs as their first senior job. So please think about it. Current RBF guidelines do not allow purchase of supplies, not even for emergencies. I've been to several regional referral hospitals, including general hospitals and health center 4s, and obviously downwards. And you cannot find a gray or green cannula, but you are managing emergencies. But you have the money, but yet the money is gazetted, please do not procure. I don't know, to me that one, you call it madness. You cannot save a life, you have money, you cannot save a life. Because that one, I think we need to think beyond that. Medicines, vaccines, and technologies, we appreciate the response to discrepancy. NMS is very fast to respond to discrepancies. The order fulfillment has improved at least to above 90%, and we also appreciate the redistribution strategy, okay, which is very good in addressing stockouts in facilities. But of course, we have various challenges, and yesterday, all of us listened in. Inadequate budget allocation for what? For essential medical and health supplies. So mortality, the issue of mobility quantification is not what? Is not practical. And that is very, very, very challenging. Delays in delivery of essential medical and health supplies. Or we can't talk about today. And of course, I think there is something that we need to revise. You are in cycle 1 for some zones. You are in cycle 1, like I'm in zone 3. So zone 3 makes its order when cycle 1 is ending. And then you expect deliveries in the second cycle. What you have patients used for the first cycle. I think there is something that we need to do and support the national medical stores and ourselves to make sure that the community we serve does not suffer. There are lots of stockouts recently, ARVs, anti-TB drugs, and anti-malarials. There is no inventory management office at Health Center 3. I don't know whether the new structure addresses that one, okay, and when it will be implemented. Medicines combined delivery is becoming very common. We do not know why. Cycle 1, cycle 2, cycle 3, cycle 4, at once. What have these patients used in the previous 6 months? It's just an issue. And you have politicians, and you have the community, and then when they see a vehicle carrying the vaccines, they know they have delivered medicines. And so the health workers have sold this what? Have sold these drugs. Okay, something that need to. Health information. We appreciate the ministry and IPs for the existing functional DHIS2 and the reforms. We appreciate the technical staff availability and the mentorships that have been ongoing. But of course, you know, we are challenged with issues of internet, electricity. Common component has not taken off. Community component has not taken off in some districts. And you know that we're losing a lot of data, okay, at community level if we can't capture it. Then we have inadequate supply of tools. There is this assumption that IPs will supply the tools. But these are just assumptions, really. I remember when I posted on the platform, the commissioner very quickly responded and says, he inboxed me. He didn't want to inbox on the work platform, but said, please, we are going to mobilize some. You get it? But you don't have a stock book. Where are you going to put what you are given? And several other several HMIS tools. Okay? Then changes in data tools now and then, probably without bringing the other people on board. Service delivery, I'm about to complete. We appreciate the functionality of the emergency medical service. I think this is very, very good and has been very useful in our settings. We appreciate the upgrading of facilities, which have, yes, Commissioner, thank you very much. Please, you clap for emergency medical services. Yes, because you have seen the ambulances. Now you can get an ambulance. You can even get an ambulance with ICU. You get it? So that is very good for Uganda, okay, and all of us anyway, okay? Then community willingness to seek for services. The community is actually very, very willing, okay? Maybe the disappointment is on our side, okay? And we also appreciate the partnership support. But of course we have challenges that some districts do not have implementing partners. They sound so many, but there are some districts that do not find partners. There are districts that have not had partners in the area of maternal and child health for decades. But you know, when you are rating, you have to match all districts same way. I think that is also needs to be put into consideration. There are access challenges in some districts. Okay? That one the commissioners know very well. Then we have obsolete and reversible equipment in most districts. So you find you need to visit one regional referral hospital and see how much equipment they have. There are rooms which could house even 20 or 30 patients, but it's just full of what? Broken beds, etc. And this happens downwards, even at health center too. Expired drugs, so many things. Those ones really hamper service delivery. Then flow of information and flow of information. It is flow, not follow. It is the flow of information and feedback from Ministry of Health to districts. not timely. Sometimes you have to beg. You have to beg certain offices for a platform. No feedback. That one has to change. That's why we say we need a desk as DHOs, okay? And health development partners, not evenly distributed. Is it possible that at least the Ministry of Health can be in charge of implementing partners, and then you know where to distribute them? Whereas we have the so-called district-led programming for IPs, can we also have ministry-led programming? So that when IPs come, they say, yes, we have come, but you know where problems are, and they go where problems are. To solve these problems, to help functionalize the system. District upgrading of wireless center tools was selectively done. Other districts have not realized this. Infrastructure, we appreciate the infrastructure developments undertaken, and we pray for more. We have seen with gladness the new infrastructural designs to address the new HR structure yet to be implemented. That's very good. But of course, we need to take note that we have inadequate infrastructure, especially for critical staff, across the districts. We have many districts with no vaccine stores, even medical stores, okay? Apart from this other container that was given by National Medical Stores. No mortuary and incinerators in most districts, the health center force especially, and general hospitals. For me, I usually tell people, even in my that when I die, you must take me to the mortuary, clean me, examine me, establish the cause of death, and then after you have done the necessary, okay, take my body and rest it. That is what I want, and that is what fits all of us. Don't be in the other category where you say, when you die, they rush you very fast. No. And the lotting of gift products should be revised as this affects progress of works. Thank you very much.
Thank you so much, Dr. Baizi. I think he needs another clap. That's not enough. The paper was very exciting. All the DHOs clap. Now that your clap is very small, that means that you did not appreciate his paper. I want to thank Dr. Baizi Newton, who has represented a nice paper on behalf of all the DHOs. And I'm sure all participants, we have listened carefully and taken note of especially the challenges, which are many, that have been raised in the presentation. It's my humble request if I can have a copy so that I could internalize the paper. And I am sure that at the end of this session, when we reach our discussion time, many of the challenges that have been raised will have been addressed. And in doing so, the most challenge that I have seen, which came as number one at the forefront, was that the DHOs do not know where they belong. So I don't know how even they found themselves here. But then we are going to get an answer. I think they have their letters of appointment, the job description, but they have a point in it, I think. They want to be told that this is our home. So at the end of that day, somebody will have to come and tell us where do the DHOs belong. And I'm sure by the time we reach there, the permanent secretary would have come. Mr. Kiri, Under Secretary, come. Come, sit here next. Come. Clap for him. You know, for us, we just give political guidance. But the technical people, you see, that's why I was looking. The permanent secretary, once you see the under secretary, that means everything has been taken care of. And I am sure he's a very seasoned finance and administration issues which have been raised. So I don't need to burn myself on that. However, the next presentation, before we go to discussion time, is a pre-GRIM field visit findings report. And I'm sure this report and presentation is going to address, again, some of the issues that have been raised in the first DHO's presentation. It will really pass to follow. Therefore, I want to call Dr. Bate Sachagri, Assistant Commissioner CAPP, to come and present our next paper. And I'm sure he was also listening. In his presentation, he will touch on some of the issues, because somehow, somewhere they are local government based. And in your findings, I'm sure you came across some of them. And why we are all here is to ensure that we go back with some answers. I thank you.
And protocol observed. Good morning, ladies and gentlemen. My name is Agure Batesach. I'm Assistant Commissioner, Inspection and Compliance. I sit in the SCAP department. Honorable Minister and members present, I am here to present the report from the field visits that we conducted before this GRM. And this took place from 17th from 17th of October to 20th of October. And we set out with the following objectives. One was to assess the performance of some districts and regional referral hospitals in last financial year. And number two was to identify the areas of priority for planning for 2024-25 financial year. And the criteria we used for...
Just one moment. As you are beginning, can we all of us welcome the Minister of State, PHC, Honorable Margaret Muhanga Mukisa, and I am sure she came in at the right time. Unfortunately, she had on her way what the first presentation from the DHO representative mentioned from the local government. She has been outside there, and she will take a lot of interest in what the findings, where we are in the second paper, and she will address some of the issues as well. You are most welcome, Honorable Minister. You can now go on.
Thank you, Honorable Minister. The criteria we used to select the districts and regional referral hospitals that we visited, we put into consideration the performance of the local governments in the league table of 2021-2022. We also considered the hard-to-reach status, the regional balance, and the new districts. And we wanted to identify achievements in these districts and areas for improvement, and we came up with a number of actions, which I'm going to share in this presentation. And these are the districts that we visited. Karenga there, that was number 86 in 2021-2022 league table. You see Ushenyi at the bottom there. which was number 2. We also considered the NMS and the GMS. And you also look at Nakasongola, which was the 115th as one of the poor performing districts. So that was part of the criteria that we used. And the areas of focus, we considered the building blocks, and under this we have governance, human resource, medicines, infrastructure, issues around maternal health, malaria, EPI, and community and school health. And sorry about that. And our findings, I want to report to you, Honorable Chair, that are not very different from what has just been presented here by the DHOs. One is that under governance, the boards of regional referral hospitals, most of them are functional, and I'm happy to report that a number of districts have functional HUMICs, and these have been trained by some partners in those regions. I want to quote Ankole, Chigezi, Acholi, Lango, and Bogisu, and Usoga. We know that we found out that Usoga thank you. A few districts have trained their HUMICs. Support supervision is being conducted in most of the regions in this country, and I'm happy to report that a number of regional referral hospitals have taken interest, have taken lead to do support supervision in the local governments, and the specialists are being involved in this support supervision, and the areas that they find wanting in the districts, technical areas, a number of medical officers and other cadre in the districts have been taken on to regional referral hospitals for mentorship for 2 weeks, especially those hospitals that are running the G2G funds. And I think we think that this is a very good intervention by the regional referral hospitals. We also noted that there is use of data from the HMIs and other sources. This data is used to identify areas that need support supervision, and this is what is used to inform the areas to emphasize when support supervision is being conducted. We also found out that a number of regions are involving districts to form teams that go to do support supervision. There is improved implementation of performance reviews. Yesterday, one chairperson of a district proposed that we regionalize the performance reviews. But I want to report in this presentation that a number of regions have begun carrying out regional JRMs. Kabale, Chigezi is one of them, and Lango, and even Acholi. So this is taking place in some regions. I want to also report that we found that Bushenyi and other districts are doing some peculiar things to improve performance. At the beginning of the financial year, indicators are shared between the among the health workers and even the political leadership of the districts. And these are monitored quarterly, where the DHO makes a presentation in the district council every quarter. And we thought that this is a very good step to improve performance in the health sector. And in Bushenyi again, district health team members are assigned to facilities which are performing poorly, for them to be able to monitor them and support them to improve. And the areas of improvement, we found that a number of districts, the top management there, are not being involved in they don't get involved in the monitoring of health services. We don't see cows, we don't see the council, political leadership, are doing monitoring for health in their districts. Number 2, we found that among the DHTs, there is a lack of coordination, lack of teamwork among the DHTs, and irregular DHT meetings. Many districts don't perform performance reviews. They only participate when they're invited by the regional referral hospitals to participate in the regional performance reviews. But for them as districts, they aren't doing their own quarterly performance reviews. And there's also need for us to improve the monitoring of the functioning of boards and HUMICs. The other area is poor access to guidelines on the boards and HUMICs, and the inadequate use of data to inform decisions in the districts. Those that have are doing performance reviews, if you look at what they have reviewed this quarter and look at their data, they don't correlate. They just have a format that every time they review everything as far as indicators are concerned. That's not productive. We think you should use your data to be able to identify areas that need your attention in your performance reviews for improvement. Under budget performance, we noted that most of the districts received 100% raises of the PHC, and all districts and their leaders there appreciate the fact that PHC funds go directly to the districts, to the health facility accounts. And the RBF, we found out that has been instrumental in improving the systems there. We note a lot of innovations, constructions, and beautification in health facilities. We also note that a number of health workers were motivated by this RBF, and it reduced absenteeism in the health facilities. There was no cause for a number of health workers to do moonlighting when they were assured of getting a bonus from RBF. Partner support is available in all districts, in most districts, but we also want to emphasize that there are some districts that lack the support of partners. We think there should be a rational manner in which partners are distributed across the country to support all districts. Most of the releases are displayed in health facilities, which we think is a very good sign of transparency as far as finances are concerned. Areas of improvement: inadequate funding for DHT or DHO's office. We think that, and it was also reported by the DHOs and the other officers in the districts, that the 15% of PHC to DHO's office is not adequate for them to do the support of the services in their districts. There's need for us to think about another formula to support funding to the DHO's office. Inadequate partner coordination, I alluded to this earlier. Delayed accountability in districts, we found this. We found some districts, a number of them, still struggling to account for funds dispersed to them for health activities. And there were reports in the districts where some of their accounts had been suspended for non-accountability. I like the confession from some of the DHT members there about this. And this was also discussed yesterday about delayed accountability or non-accountability of funds. But there's also a lack of accountability or adequate accountability, which we call social accountability. Communities don't know much about what their DHOs or DHTs are doing as far as health is concerned in their areas. So there is also need for us to think about community accountability. How do we account to our communities that we serve? Under human resource, we note that though some districts are well staffed, these are still being bedeviled by absenteeism. You find a district like Mayuge at 92% staffing, but absenteeism is taking a toll on their performance. However, there are some districts that are still struggling around human resource. For example, Busheng reports 57% staffing. Majority of the staff are appraised, uniforms are available, and a number of staff have name tags. Most districts are struggling to do attendance to duty monitoring by use of registers at their facilities. And I want to report specifically about LIDA. LIDA have tried to link the IFMS system to the reporting to duty. And when you don't clock 20 days, you don't see salary in your account. And Buyende district, for them, they have innovated. They sign performance contracts with their in-charges. Health facility in-charges sign performance contracts with the DHO and the CAO, and these keep being monitored quarterly, and by the time you are into third quarter, you know that I'm in charge, but according to my performance, I am likely not to be in charge in the next financial year. We found this very interesting, and we think something that can be copied by other facilities, by other districts. That's just a performance agreement signed in Buyende. Districts are doing recognition and reward for good performance. Jinja is one of them, Bushenyi, and Sironko. Welfare for staff, we find that a number of districts, staff are struggling with welfare, especially when a calamity befalls them. For example, if a staff lost a dear one, it's them that collect some mabugo among themselves. There are no formal methods of them being supported because of the limited funding. But Bushenyi and Kanungu have good examples. They are trying something at a loan scheme for staff. Areas of improvement, most DHTs are in acting capacity. Members of DHTs are in acting capacity, and some of these are DHOs and ADHOs. We think this is something that we should work on to get these colleagues in substantive appointments. Shortage of critical staff, as discussed yesterday, we also saw it in the field. These include medical officers. Buyende is an example. Buyende doesn't have any medical officer on payroll, yet it has 2 health center forces. The 2 medical officers there, they just have an arrangement with the CAO and the DHO. That's how they are being supported by those 2 medical officers. But none is on payroll. There are issues there of failure to advertise for these positions, and the other districts are quote failure to attract. And inadequate staff accommodation was also picked. Delay to operationalize the new HRH structure is affecting the local governments. And inadequate monitoring of absenteeism in most districts. I want to report this gathering that even the districts that had the biometric machines, most of these machines are broken down. They are non-functional. And therefore, you may try to figure out how health workers there are celebrating and enjoying their organized absenteeism. I want to report, Honorable Minister, with emphasis that there are some districts that are on the radar of the OPM, which were given biometric machines in the first arrangement. But these are now broken down. They aren't functioning. It's something of interest to us as a ministry. Medicines and other supplies, I want to report that our findings are that procurement plans are in place, but a number of districts missed Cycle 5 and Cycle 6 in financial year 2021, 2022, and even 2022, 2023. And there is a habit of NMS lumping up all cycles about 3 cycles or 3 cycles, and they bring them in the districts at once. After leaving the local governments to suffer for about 2 cycles without medicines and other supplies. We think this is an area that we should look into and be able to streamline. The policy of redistribution of medicines and supplies in local governments has reduced the number of medicines expiring, and we see that this is something good. I also want to report, Honourable Minister, that the RX solution, a method used to manage medicines and supplies in regional referral hospitals, is taking place in most of the regional referral hospitals. We see availability of oxygen and blood in regional referral hospitals and the general hospitals and health centers. We think that the following areas need improvement, that NMS should be able to work with the districts to get the supplies as planned per cycle, and should also be able to honor the emergency orders from the districts. We found unutilized computers and other accessories in districts. These are meant to be used for monitoring the use and availability and stocks of medicines in the districts, but they are new and they are still packed in their boxes. They aren't yet installed for use. We think NMS should be able to expedite the installation and the use of this equipment for us to be able to track the use of our medicines. Honourable Minister, some oxygen plants have been non-function for the last 6 months. An example is the one of Ginger and Lita. And the new plants are not yet installed. The districts pray that these get installed for them to be able to surmount the challenge of availability of oxygen in the lower facilities. Health centers had issues with blood supply to them, and then the inadequate storage facilities for medicines. Most of the local governments don't have medicine stores. Infrastructure, districts appreciate the efforts made to improve infrastructure in their areas, and we noted a lot of constructions and refurbishment of facilities, but I want to report in this meeting that a number of facilities that have been upgraded from health center 2 to 3 status don't have the requisite staff, and they don't receive the requisite amount of supplies as per level 3. They still continue to receive the supplies for health center 2s. I want to report to Honourable Minister that the ambulance system is up and running in most sub-regions, and there is reduced clinging onto the ambulances by districts. The ambulances are now being coordinated centrally from the regional referral hospital, and an ambulance can be called from one district and sent to another district to do support there. We think this is something positive, and a number of districts visited are very positive about this. They are supportive. We think this should continue. Districts and regional referral hospitals pray that call centers are established in every regional referral hospital to be able to manage the ambulances better. A good practice in Busoga and Lango sub-region, where districts are contributing to the fuel to run the ambulances. We think this is good and should continue. Honourable Minister, we noted that a number of equipments newly supplied to districts is not engraved, and there is a risk here of these getting lost into the communities or into other markets. We feel that that before these are supplied, when they are procured, they should be engraved before they are supplied to the districts. Regional medical equipment workshops, they are trying to support the districts, but they are incapacitated because of facilitation in terms of funding for spare parts. Funding for spare parts and the workshop trucks. I also want to report that we noted a lot of poorly maintained places of convenience, pit latrines, urinals in the health facilities. Poorly maintained, very unhygienic, not fit to be in facilities in local governments. And we want to implore the DHOs here to work with the in charges to improve these, because these are some of the areas that shame us as the Ministry of Health when patients come and find our places very, very unhygienic for them to use. And I want to report in this gathering that some of these were even places of convenience for health workers in the staff quarters. Inadequate staff accommodation, I talked about this earlier on.
When you look at our time, you find we are behind schedule. If you can try to summarize.
Just
as you see, the front bench here came in at the right time. They would also need some few minutes to respond to some of these issues.
Thank you, Honorable Minister. I want to report that all antigens were available in the districts, but we noted yesterday that we are slackening in terms of our EPI services. But all antigens were available in the districts. And I want to report that uptake of COVID-19 vaccines and the other related services is low in most local governments. COVID-19 vehicles and Gavi vehicles have been taken on by other leaders in the districts, the CAOs and LC5s. And I want to report in very clear terms that the DHOs and the ADHOs don't have access to these vehicles, and this hampers their operations. The other issue is about vaccine control books in our districts are not well maintained, well monitored. We need to do something there. I can't go from this platform without talking about maternal health. I want to report that a number of districts have equipment around maternal health. We want to thank you so much, Minister of Health, the PS, and the Minister. Thank you so much. Districts are very happy around this area. Commodities around maternal health were supplemented by RBF. We have a number of facilities running in NICUs, and these have supported them in the improvement of the outcomes of neonates. MPD SARA committees are running in most regions. I want to report here that some regions have taken on the local maternal and the neonatal services
and
initiative,
finally,
and this has helped to improve the outcomes on child, neonatal and maternal health. I want to appreciate UHSS for funding this visit to local governments before this GRM. Thank you so much.
Thank you so much, Dr. Batesachi. Can we give him another round of clap? And as I've said, you have really noticed that the two papers are related in nature and their presentation. They have raised quite a number of issues in the form of challenges. Now, can you allow me at this juncture take an opportunity to welcome our own Minister of Health, Dr. Jane Acheng, who has steered this sector up to where it is. And when you want to take the checklist and indicators of good performance, you see the challenges that are being brought up. because challenges are always opportunities. If they were not there, then that means that the sector is not doing well. I have already welcomed the Minister of State, PHC. Can we welcome our Director General and the PS in absence here? And Honorable Minister, to bring you on board, this morning we had the first paper as per our program, issues affecting service delivery from the local government perspective. The second paper, when you walked in, it was addressing the pre-GRM field visit of findings and the report therein, which you have really participated in. But in the first paper, and this goes to the PS, the Director General, and the guidance will come from the Honorable Minister and any other minister who will want to supplement. Our next program is discussions. And we have another paper by the National Planning Authority. And we are behind time. So I was thinking, if it so pleases, so that we can have the next paper. And when we start our discussions, they take us up to group formation. Because you see there's discussion, then there's discussion. And not to lose track of what we have gone through, as a reminder and as a recap, Honorable Minister, issue number 1, the DHOs are not sure where they belong, whether in local government or Ministry of Health. That is why service delivery is being affected. Right, Honorable Minister, I'm the chair now and reporting. Verbatim, leadership and governance at district level very weak because less than 60% of district have substantive DHOs and assistant DHOs. The Undersecretary was covering in. Now that the PS has come, I'm sure the Undersecretary has gone again in his back seat. I don't know why without the permission of the chair. DHOs want designated office in Ministry of Health. Hopefully they are not taking over my office to serve as a desk for coordination with the districts. That one, human resource and the PS and everyone. Human resources not enough in districts to deliver quality services. DHOs are asking why the new structure for DHO's office was not approved by public service. I'm just bringing you on board so that we are together. Because these were the issues. Fact that absenteeism is organized. So we need to know this organized absenteeism and how we can deal with it. So at this juncture now that everybody is on board and we have recapped what we have gone through in the two papers, can I call on the National Planning Authority? I have not been given who is the presenter, but I'm sure the presenter is there. He or she can come up and present us an update on progress. Is someone from National Planning Authority here with us? Yes, can we know who she is, at least briefly, so that Dr. Okware, that is not only you who knows her, so that we should know who she is, but she can do that one as she presents. The paper is updates on progress of implementation of the NDP 3, Human Capital Development, which was covered yesterday, program and key priorities for the NDP 4. Over to you, Madam, from the National Planning Authority. And you are going to have 5 minutes. 5 minutes, Sarah, don't say
Okay.
International time for presentation, ask the Minister, Dr. Jane, is 3 minutes. And we should clap for her. She has always lived in that presentation. And mine at international is 5 minutes. And I've always lived within that. So can we also try to live within 5, okay, 7 minutes to the last. Thank you.
Thank you, Chair. Good morning, ladies and gentlemen. Protocol observed. My name is Judith Mutabazi. I'm currently heading the Department of Population and Social Sector Planning at National Planning Authority. I'll take you briefly. I'll give you the highlights of the midterm review we conducted for NDP 3, just to bring you on board, and the issues are not very different from what the previous speakers have presented. I will go to the first slide, no, to the third slide, since I've given. Okay, so the slide on the screen shows that the overall performance of the third National Development Plan after the 2 years of implementation was at 17%. And this 17% is contributed to by all the 20 programs. And if you can see probably in the row number 5, at output level, one of the key issues, we didn't have a lot of data. Most of the output indicators we planned, we didn't have data to report on the progress of implementation. And of course, and various other challenges also hindered implementation of the plan. So that was overall. This is just an insight of the Human Capital Development Program, one of the 20 programs in the plan. And it has 4 sub-programs, as you can see. So population and health is one of the key sub-program under the Human Capital Development Program. So the program background was built on the challenges which have been expressed by the previous speakers: weak foundation of human capital, poor population health and safety, lack of an institutionalized and integrated human resources planning and development, which is not only for health, but also for other sectors. Education, we have challenges. Local government, we have challenges. Human resources across the board. So these are some of the issues that builds foundation of the priorities we've set out to achieve under Human Capital Development Program. And the goal as we are still implementing, we are in the 4th year of the program of the NDP 3, and it's still productivity, labor productivity, and increasing competitiveness. So the program has 6 objectives. Ministry of Health, or the Population and Health Sub-Program, contributes mainly to Objective 1, that is improving foundations for human capital development, and Objective 4, improving population health and safety and management. So the others also, it's not like you don't contribute, but you contribute to them indirectly, though not directly. But if you look at the plan and the program, it's basically those 2 programs where we've mapped your strategies and priorities. I'm trying to summarize given the time I was allocated. These are the outcome indicators in the programs in the third National Development Plan. We have outcome indicators, we have output indicators. Outcome are the results at higher level where we are contributed to by the different stakeholders under the program, but at outcome level, at output level, that's where specifically we map the different MDAs and in line with the interventions, and it aligns to the resource allocation as well. So these were some of the output, but I think these are not directly related, though like years of schooling for children, health contributes, because we have a lot of, like, for example, teenage pregnancy, health of the children also is part of health responsibility, and that's where the program approach becomes very relevant. These are some of the outcome indicators. Also, we have about 20 outcome indicators in the program, and this is what we monitored in the midterm review, progress on implementation. And you can see some of these, especially accessing universal health care. We had a target to achieve 65 from 44, and we haven't achieved much in line with this. Reducing neonatal mortality, we had planned to reduce it from 27 per 1,000 to 19 per 1,000 live births. Under 5 mortality, we had planned to reduce this. Reducing prevalence of stunting, unmet need for family planning, and then reducing the gender gap. Some of these indicators, this is what we achieved. If you can see, we have some reds where we have not achieved much. We have some greens. Greens shows that we have achieved some progress, and that is specifically in the stunting and the under 5 mortality, maternal mortality, and unmet need for family planning. But the rest of the indicators we have not achieved as per targets defined in NDP 3. Although this was done even before the UDHS was launched last month, but we still see under maternal mortality and infant mortality, there has been noted some progress, but other indicators we haven't achieved as per planned. We have core programs under the Human Capital Development Program and the sub-program for health, that is in the second row. You can see we have core programs, and specifically that is the Heart Institute. It was still at feasibility study by inception of the third plan, and we had oncology centers that were supposed to be developed in Gulu. It's still ongoing, and one of the findings in midterm review was most projects, core projects that were put in NDP 3 were still either at idea level or at conceptual level. And a lot of time is needed to carry out feasibility studies, which hinders implementation. So you find progress was not attained because these core projects contribute to the results of the program. So a number of challenges, of course, were noted. As we transited from the sector approach to the program approach, we needed a lot of collaboration and synergies among the MDAs and alignment, so it also affected alignment and implementation of the NDP 3, delays in procurement processes for most of the projects, poor planning and prioritization of activities, and amidst commitment of funding, we realized funding is still a challenge to the priorities as per planned PIAPs. Staffing shortages, that was also highlighted by the previous presenters, and even yesterday, limited progress of core projects I've already highlighted on that. So those were some of the challenges affecting attainment of our desired results. Those were overall challenges for the program, but specifically for the health and population program, sub-program, the indicators were not tracked in routine health management information system. I think that is something we need to look at as we move forward. We need to track progress on implementation. And then mortality and morbidity of malaria remained very high. What are we going to do as we go forward to reduce our mortality? Double disease burden has also continued to increase for both communicable and non-communicable diseases. We noted that the socioeconomic situation affecting determinants of health were also affecting access, especially to safe water, nutrition, education, and housing. The low health worker patient ratio, it's still affecting service delivery and access to health services, medicines and health supplies, stockouts, that was already highlighted. Newly constructed and equipped health center facilities require high utility and maintenance costs, increasing population rate amidst the planned service delivery, increased number of road traffic accidents with high costs of care and long hospital stays. So those were some of the sub-program challenges. And then there were also emerging issues. We took note of emerging issues. There is increased escalating prices that also affect access to the other social determinants of health. There is unlimited digitalization of health information systems, and this really affects service delivery. Increased morbidity of injuries, it was noted it's very high and affecting most of the health centers that are providing the services. Global shortage of health workers leading to labor externalization, hence the shortage of health workers in the long run. Low health workers to patient ratio, I've already talked about that, and most of the challenges which you've highlighted since yesterday. So going forward, we thought the program priorities would still focus on those challenges that we've highlighted. So we are not going to digress a lot. We are still in the fourth year of the plan, but we think we should continue focusing even in the forthcoming plan, the fourth National Development Plan, because we haven't achieved much. If we are still at 17%, I don't think the status has changed. So priorities going forward, we think we should focus on digitalizing the health information system, rehabilitate and expand the existing health centers and general hospitals, provide scholarship to train cadres, revise our human resource structure to be aligned to the service delivery, maintain investment in prevention and control of intervention of HIV, AIDS, TB, and malaria, then also promote research and innovation of the pandemics. And other priorities, we think we need to implement the NDP3 suggested projects so that we can be able to address some of those priority areas, especially in the non-communicable diseases, strengthen emergency medical services, that is particularly establishment of the trauma center at Naguru and regional ambulance call and dispatch. These were priorities in the NDP3. That's why we're picking this, and they were not implemented at all. Fast-track efforts to establish a national health insurance scheme, policy shift from management of drugs to allow health facilities to retain funds to cater for buffer stock and stockouts, increase investment in community health programs for health promotion, diseases prevention to reduce the high burden of diseases. NDP4 roadmap. We've started on the thinking through of what we are going to do for the next plan, which is starting 2025-2026, in line with our Vision 2040. And we are waiting cabinet approval. If you look at the roadmap, cabinet approval, we had thought it to be secured by this month, November, and it's already, the draft is already with the Honorable Minister of Planning. Once it's forwarded to cabinet and approved, then the next action will be to develop background papers, issues paper to inform priorities either in your sub-program, population and health sub-program, and also to inform formulation of the program priorities. Then we go into consultations of MDAs, local governments, NGOs, development partners, and other stakeholders that contribute to this program. And that is supposed to be done by January. We expect 2024 to have started these various consultations at all levels, and then develop the macro framework paper, also that is part of the plan, the M&E framework, that is where we define our indicators that are going to help track progress. And then we expect to have a draft by September 2024. And this is in line with informing the next budgeting cycle for 2024, when we shall be developing the BFPs for the first year of NDP4, that is 2025-2026. So the rest of the months remaining will be to formalize approvals by His Excellency, Prime Minister, Vice President, and then disseminating the report to the various stakeholders. So currently that's what we have, the roadmap for NDP4, and the findings. The midterm review was specifically done to inform the formulation of the next plan, and these sector reviews will also guide on how to come up with the priorities, strategic interventions, and indicators that we shall have as we go forward. Thank you for listening to me.
Thank you so much, and can we once again appreciate the presenter for a very comprehensive, well-structured presentation, well-detailed, which has addressed some of the major challenges and given us hope on the way forward. We want to thank you so much. And the three papers, we can see that they are all related in nature. They raise challenges, then they raise on the way how to address these challenges. And in our discussion, we are going to focus so much because the challenges are many. And if we add on more challenges, we shall be lamenting. And I was told that the book of Lamentations was raised by another book of answers. So now we are going to have the answers, which will be answering the other side of the Lamentations. And our discussion will be guided by the papers that have been presented, unless there is a very, very other issue. As I have said, the permanent secretary, most of these issues, should have a say in her discussion time or as she addresses some of the challenges that have been raised and have not been addressed within the other papers. For example, the issue of organized absenteeism, I have seen and have heard her most of the times. I have seen her communications, the issues of monitoring and supervision at the district local level, and of course the staffing. So I open now the floor for discussion. We shall take, you can just, when you raise up whatever question you are raising, your observation, you can mention that one is for the Minister for General Duties, Minister of State, this one is for PS, this one is for the presenter, so that you get the actual answers. We shall not limit the answers to the presenters only, because you'll find others hinging on policy, others administrative, others are finance, and the team we have here, others are for Director General, who is the general head of every health services in this country. So feel free to say, my question goes so and so, or my observation is this and that, so that we don't limit them. Others which are touching on planning, our Commissioner, Dr. Sarah, is also here to supplement. But I want to thank that much of the issues that the presenter on the National Planning Authority has addressed some of them. The floor is now open for discussion, and 15 minutes. Thank you.
Thank you, Chair. My name is Chiberun Sobuga Charles, Chief Administrative Officer, Chirura District Local Government. I have about 3 issues. Number 1 is the issue of staffing. Honorable Chair and the Honorable Ministers present, I think we need to be more coordinated in this. Yesterday, the Honorable Minister hinted on some issues which I agree with her. The issue to deal with leadership, the issue to deal with the mindset, but I also to add on something called willingness by the leaders, and also thinking out of the box. Last year we had a meeting where the PS Health and the Finance had invited us over accountability issues. And the issues of DHOs, staffing of DHOs was raised. And we resolved that we should recruit immediately. But later on, I think a bullet came and said, don't recruit. That's why I'm saying we need coordination. But for some others where I can say in Chirura now we are 79% staffing, because I think of the willingness and thinking out of the box. That's one of the things which I felt we need to follow what we had resolved. It is also embarrassing that government through Egypt has spent a lot of money in building infrastructure, and then we shoot ourselves by failing to operationalize them. And one of the things I raised, I think in one of the meetings, is that we spend billions to build, but we fail to facilitate even the service commission. And my argument was, can't we get 0.1% of the Egypt fund and facilitate service commission to recruit? Because the structure are there, billions, but you are failing. The budget of service commission, I think this year now is 18 million. but was even 6 by then. It has also been raised.
The last one?
The last one, Madam, about NDP. I think in the presentation, she did not present the issue of the challenge we went through as a country for 1.5 years of COVID. And I would think, is it necessary now to have another NDP other than rolling over this one because we are at 17%? Thank you.
Thank you so much. Those are 3. I'm sure the PS will respond to some. Dr. Kware, if you can pick and give the mic to somebody. Give.
Yes.
No, whoever has a mic, you get it, you speak.
Yes, I have the mic here. Thank you very much, Chair. Asiko Abdul Mutwalib is my name, the district chairperson of Yumbe district. In the presentation regarding the district-specific issues, there has been an observation regarding infrastructure or in most of the facilities. And indeed, when it comes to infrastructure, it affects critical service delivery, especially the issue of staff accommodation is very key. And also when you look at government policy regarding upgrade of health facilities to ensure that at least every sub-county has a health center 3. We still have challenges of resources in regard to this. I want to thank the ministry that we have had the AMCHIP program. And this program is coming to an end. We also have the UGIFT, which is ending next year, but still there are a lot of infrastructural challenges that we have in our health facilities. We may not necessarily be relying on the sector conditional grants for capital development, because when you look at the IPFs for the sector conditional grants, they are so limited. I want to pray that as we are for this GRM, there is a need for us to continue to engage our donors so that we get more resources as successor programs for the AMCHIP and UGIFT. Otherwise, we still see as district leaders, we have those huge infrastructural challenges. There's been a mention about staffing, and I want to observe that Yumbe district has 47% staffing levels as of now. The director of Jinja Regional Referral Hospital is here. He was the DHO of Yumbe district, and he'll be able to confirm this. Initially, our staffing was about 57%, and this has come down to 47% when Yumbe Regional Referral Hospital was upgraded as a regional referral hospital. So the staff within the local government structures were validated to join the regional referral hospital. This continues to affect service delivery. I would want to pray in this conference that if we get specific interventions, yes, we have the ban, and we'll still continue to talk about the ban, but where there are issue specifics to the districts, this will be of interest so that we continue to push Minister of Public Service and Minister of Finance to allocate additional resources. We have seen that there are some districts are doing well. So if a district like Yumbe has 47%, it has an impact in the performance targets in the league table. I beg to submit.
Thank you so much, Dr. Okwaro.
Thank you very much, Honorable Minister.
Participants, where you find that an issue has been raised, let's raise a new one so that we have as many as possible for other people also to contribute. When you find things like staffing and the issues on understaffing, that becomes a general one. Then we take note of that so that we allow as many. That's why we are here to share our different problems and challenges in our districts. Thank you.
Thank you very much, Honorable Minister. Dr. James Justice Elima is my name, Hospital Director, Masaka Regional Referral Hospital. I want to start with a good note that, Honorable Minister, we gave Uganda Blood Transfusion Services land in Masaka to build a blood bank. Top management has approved it, senior management has okayed it, and we're waiting for the board, which you are supposed to inaugurate very soon. And however, it comes with some small condition that they will have to build the gate, not a hotel gate, but hospital gate. Honorable Minister, there is some small issue brewing in local government. I'm seeing people pushing that they want gynecologists to be in charge of maternal and child, ADHO, maternal and child health. Unless there's a policy instrument on that, please let's not go that side. The health sector is very encompassing. Let all accept that other colleagues should be able to run their part. And then, Honorable Minister, this issue of absenteeism and so on, I think let us not throw it away. One is that I want to take from the minister, let's take responsibility in our hands. There are health centers with the health management, all health centers have health management units. And these health management units have chairpersons. The health center 3s and 4s, they too have health management units. Let the local governments take it upon them that the parish chiefs and the sub-county chiefs prepare documents and send it to the resident district commissioners. And this is the resolution we came up with in our regional joint review. If you can set a security meeting about land eviction, about murders, why don't you why don't you discuss a minute about absenteeism, about drugs, about everything in the district security meeting? So, issue of absenteeism must be a district security meeting issue. Lastly, Honorable Minister, I want to talk about the issue of I was a DHO in so many districts. By the way, I'm your spy. My umbilical cord still remains. I will never run away from it, from local government. This is now an opinion. What if we repurpose the position of Director Health Services, Public Health, to be in charge of DHOs? This is an opinion. We repurpose. We are not creating a post. We repurpose it. Can top management, senior top management accept that? Can there be an effective policy instrument or policy tool on that? Because the DHOs are crying. I was there. I also cried. Is that okay? So I think let us discuss that. Let's call them and meet them and discuss it. Otherwise, thank you very much. James Elima is my name.
Okay, thank you. I'm Dr. Nkoyoyo Abdallah, the project director for USAID Local Partner Services in Ankole. Now, there are two issues I want to raise. The DHO of Chivoga ably brought out the challenges that they face as the DHOs in the different districts. But yesterday, when we were reviewing the sector performance, it came out that the sector has been unable over time to burn the funds that have been provided to them. Now, I thought that this is largely at the district local government level. But in his submission, this one did not come out. I would like to ask, should we take this failure to ban to be at the central level? Is it with the Minister of Health? Because if it is with the local government, I think it is high time we brought out the root causes in this meeting so that we are able to sort them here with the relevant authorities. Secondly, this one goes to the Minister of Health. It has come out clearly that we are all moving towards digitalizing the health services, especially with health information systems. But it comes to us that many of the health facilities are not connected to the main grid, the power grid, electricity. And this one affects our ability to expand the services, the computer services to most of the facilities in the rural areas. Is it possible for the Ministry of Health to work together with the Ministry of Energy or any other relevant government authority to ensure that the health facilities can be connected to the grid so that we are able to easily digitalize the health information systems thereafter? And then secondly, related to that, there are many districts where I operate, where the where the electricity grid is frequently cut off. Specifically in Chiruhura, Kazo, those districts can never have electricity for more than 2 days. Now, this one affects service delivery in those facilities. And sometimes it results into loss of supplies because sometimes they switch on equipment and they use cartridges. And then when the electricity goes, such logistics are lost in the process. So I would like to request for that support to ensure that the health facilities are connected to electricity, and where they are connected, maybe they should not be cut off, because I know authorities can do that. Thank you.
Thank you. Next.
Thank you, Chairperson, and thank you, the presenters. My name is Kenneth Akiri. I'm the Undersecretary in the Ministry of Health. I have 2 observations and 1 question. All the presentations were structured around the health systems building blocks, and one of the building blocks is governance and leadership. And I know for sure we have structures from the lowest level up to up, and all these structures have different mandates. Now, the key question is, why is it that we have these structures not effective at the level where they have been created? What is the challenge? Because when Dr. Baizu was presenting, he indicated, all those structures, and he highlighted challenges they are encountering, but we didn't seem to get to the bottom of why are these structures not accountable for the mandate that has been assigned to them? What is the limitation? If you look at the issues again that were highlighted on issues of sanitation facilities not being cleaned, and you look at very, very funny issues at the service delivery points, why is it that these people are not able to do exactly what they are supposed to do? Number 2 is on the block of service delivery. On this one, when you look at our theme again, we are on community, leveraging on community systems and approaches, But on service delivery, I didn't seem to see issues that touch the communities. Why don't we have, for instance, these people undertaking outreaches? Why don't we have the DHO and other health officers and in charges, for instance, appearing on radios and sensitizing the masses? If you are looking at disease prevention, why is that missing out? What is the challenge? So that maybe we address some of those issues now. Lastly, is on the issue of the health of the indicators. Even NPA, when they were presenting, they indicated quite a number of indicators do not have data. Why? Why don't we harmonize our planning, that if we need surveys or whatever kind of data collection mechanism, it is planned in such a way that at a point of reporting we have all this information collected. Because if you are doing a midterm review for NDPA or NDP3 and you indicate that there is no data for the indicators that we set ourselves, I think for me it poses a question for those who are listening. Why? Thank you.
Thank you so much. I'm told there's someone on online. If we can allow that one, and then can we have someone on online? Then after that one, we shall have the. We can't hear. ICT. data is very important. Communication is. We shall come back to him as our ICT.
Why can't he speak?
Thank you so much. You have the floor. We have lost you. Can we have Director General? I say the mic. If you have a mic, then it will be easy for me. You put up your hand, you get a mic, then you speak, and that's the procedure. Thank you so much.
Thank you, Chair.
Thank you very much, Madam Chair. I think the Chair allowed me first.
I did.
Yes. Thank you very much, Madam Chair. Apologies for coming late. I had to sort out something brief in the office. I really wanted to add to what, Henry Mwewesa is my name, DG. I wanted to add to what Kenneth talked about Akiri. Today is our day 2, and we are closing today. I've just quickly run through the presentation of the DHOs, and I also saw some of the presentations. I think at this time, we have the DHOs here, we have the hospital directors here, we have the district leaders here. So at this time, we should not be throwing challenges, complaints, issues. At this point, we should be discussing what is the way forward. I don't want somebody to stand up and start throwing another challenge after challenge, lamentation after lamentation. We have just today to close, and we need to agree going forward what should we be addressing. Otherwise, we will not have that time. We have the DHOs here. I wanted them to hear them say, advise us. We have accountability problems in the districts. How are we going to address that going forward? Absenteeism has been talked about since yesterday. I would want to hear somebody say, I think this is what we are going to do to address the problem of absenteeism, to make sure that people deliver on their outputs. I have not heard that come out. I want to hear somebody talk about, we talked about declining antigens. I want to hear somebody tell us, this is how we need to address this. And we discuss those kind of things. I want to hear somebody tell me, health center fours which are not doing cesarean section. Really for me, if you are a health center 4 and you are not doing a cesarean section, then you should be a health center 3. There's no point for you to have a doctor there. You can't do a cesarean section and you are earning money. So all those lists of the number of health center 4s that we listed there yesterday not doing cesarean section, something should be said here. What do we do about it? Our emphasis in this meeting has been community interventions. I have not heard anybody say now, let's do this in order to strengthen community interventions. Extra. Let's be guiding on what we do so that we don't come back next November and we are lamenting the same things. We are raising the same things. There should be a difference next year from what we are saying today. And that would be a useful way of using our time here. You have 3 ministers here, you have PS, you have all these district leaders here, and then you leave again as usual. I don't think we'll have used our time usefully. That was my point, Madam Chair.
Thank you so much. With that guidance from the Director General Health Services, and which I think is timely, and the next discussants, I'm sure we shall follow the same line, like Dr. James Elim of Masaka had given a way forward on absenteeism, and he said that this should be put on plate of the District Security Council, and even went further to the sub-county and meetings. Therefore, we need to be structured in the way that when we are addressing challenges are there, but then there are opportunities of how we can address them. There is somebody with a mic. If the people with a mic can walk, yes. I'll start with one from here. I'll go to the other one. They hand off a mic to the other last one. I want gender. Now, too many.
Thank you very much, Honorable Minister.
You can stand up so that they see you
Richard
clearly.
Rwabuhing is my name.
And we follow the procedure by DHG.
District Chairperson Kabarola and President Uganda Local Governments Association. Honorable Minister, I wanted to provide information about the COVID vehicles being used by other departments in the districts. Honorable Minister, Honorable Chair, government departments play a complementary role. And we appreciate the Ministry of Health did provide these vehicles, and they are doing a very commendable job in the local governments. However, Honorable Minister, apart from the vehicles provided, the fuel, the services, the tires, and every other thing comes from the other collections within the districts. And apparently, it is only the COVID vehicle and the extension vehicles, which are sound vehicles in all the 135 districts countrywide. The rest of the departments don't have sound vehicles. And once in a while, not always, I do appreciate that we borrow these vehicles, but it's not permanent. For example, you don't use that one in my district. And yet yesterday we were among the last 10. So it is not that it is the vehicle which brings about performance or not. But one thing I wanted to bring out clearly in this meeting is that as departments in the district, we complement each other, and let us not create animosity between one department and the rest of the departments. It will be counterproductive and will not yield. But we appeal that no department should hijack the vehicles, but rather we support each other once there is need here and there. And that one, I think, is not a crime. Finally, Honorable Minister, on the issue of the DHOs, they don't know where they belong. I think this is not correct. It is not. Because we operate under a decentralized system of administration as a country which is constitutional, and the DHOs know their line of appointment, their lines of reporting, they know who to report to. I do know that the ministry certainly play a supportive role, which we appreciate. The guidance we do appreciate, but for a mention to be that the DHOs not to know where to report is not very correct. I think that impression must be corrected. We operate under a decentralized system of administration. There has never been any constitutional amendment to recall the decentralization, and therefore we know where we belong and where we report. I thank you, Madam Chair.
Thank you so much, Chair, for Daruga. The other one?
Thank you, Chair. I am called Joseph Lomongin.
There is another one last there. He has been standing tall.
I'm called Joseph Lomongin. I'm the Chief Administrative Officer, Uganda District Local Government. One of the concerns that I wanted to share has been already shared. Yeah, chaired by the district chairperson, Kabarole. But I just want to add that when you look at the job description and specifications of local governments 2011, our relationship with DHOs in service delivery is that the CAO is responsible for all heads of department, including DHO. And the same specification and job description says the DHOs report to the CAOs, the accounting officers. So that's our relationship at the context or perspective of local governments. On the issue, the concern of having no substantive DHOs chair, I've been in commissions, I've been human resource. I think one of the challenges, despite the fact that most medical officers, senior medical officers, have all the academic requirements, but sometimes the commissions are very strict in terms of the experience of the 9 years and then the level of career growth of senior or principal. So what I would recommend is that case by case, some districts have always requested for a waiver, and they are given authority to do accelerated promotion for some of the people who are now DHOs. So that's my recommendation that we should explore the issue of accelerated promotion. Thank you.
Thank you so much. DHO.
Yes.
There's a last one.
Yes, Honorable.
And we have one last,
Yes,
so that
Honorable
we
Minister.
answer the 10 first.
Honorable.
No, the other one, there's somebody there. Unless he has given up. In that last corner, yes, there. Thank you. You'd
Yes.
also come on board.
That one, you are going to see the resource workers going back to work. Now, I think that's what I wanted to comment about. Now, on the other issue which I discussed with the Director General, declining immunization. This is a very important concern, and I think I had sent a WhatsApp to the DG recently. Our immunization, we had seen it for some time and has been going down as a country, and we are in danger. And I had a problem in Kidula some time back, but I had to confront it myself as the DHO personally. Me, for the last 4 or 5 years, I made sure that I sign in my performance agreement as the DHO. One of the indicators I sign is immunization. And therefore, I have to look out to see, even if my assistant has not done the work, I have to follow up and see that children are immunized in all villages and what. So I think DHOs, for us to appear to be relevant, the first, and I've been trying to tell colleagues, the first area we should be able to address is primary sector care. If we fail to immunize our children in our districts, we are really in trouble. But also, at the national level, the Ministry of Health should support us through their program. I remember there was a time when the program manager was reminding DHOs on a monthly basis on their immunization coverages. For me, I have a system where I'm able to remind LSA workers immunization coverages on a weekly basis. And I've seen antigen is boosting up because we have a system to monitor this on a weekly basis. So I think we need to have innovations outside what is in the books to really make sure that we keep our coverages high. Thank you very much.
Thank you so much. We have had 9 and participants only remaining with 1. We have heard from the ministry, Under Secretary, and the Director General. We have heard from the President, Uruga. We have heard from a representative of referral hospitals, at least from my region in Masaka. We have heard from DHOs. Who has not been heard from? The honest, who participant group that has not been heard from? We take those ones first when time is allowing. I don't know what the MC is saying. Mine is to continue chairing. The chair is warm. Yes.
Thank you, Chair. I'm Dr. Birunji, DHO Kanungu.
Another DHO now.
So DHO Kanungu. So I want to contribute to declining uptake of antigens and other community health interventions and health promotion.
Can you hear me now?
And would suggest that in the parish development model, pillar number 4, where we have social services and parish-based management information systems, that these be integrated at parish level.
Can you hear me now?
At parish level, I expect that the VHTs should be re-engaged, and these should be some of the parameters to be monitored. I also noted that in the
ICT
mid-term review of National Development Plan 3 implementation,
Thank you so much, and I want to use my prerogative that since you mentioned the girl child, I want to give a chance to a girl child. The other girl child, the baby there. Yeah. Thank you. She prayed for us.
Yeah, thank you, Chair. I'm going to speak to low immunization coverage. I would like to assure the House here that all is not lost, much as we recorded low immunization coverage. The issue which could have portrayed us as having low immunization coverage might have originated from the data capture tools. With the introduction of the new vaccines, there were some data tools which could not capture all the newly introduced vaccines. Moving forward, if the ministry and NMS can remain consistent in the supply of tools, if METS can step up the quantities and availability of tools in the districts, I think we shall see this change. Number two, Madam Chair, the issue of financing EPI has been left to implementing partners and Ministry of Health. Local governments do not give us any local revenue to support immunization activities, not only immunization, even other health sector services. And probably that is why top management don't get involved, because they think they lose nothing. They are not seeing their local revenue in the health sector budget. My prayer, can we have an indicator that is also assessing local governments' allocation of local revenue to the budget? And so when they are coming to assess OPM indicators and local government assessment performance indicators, there is also that indicator. Maybe it will be a commitment. What we have done in our district, we have promoted performance review meetings at health sub-district level. These performance review meetings bring together the sub-county chiefs, that is the senior administrative secretaries, the town clerks, our EPI focal persons, our VHT coordinators. This is an opportunity where we review performances using the red categorization tool. Sometimes we see a lot of energy generated, but at the end of the day, if there is no regular funding from UNICEF, sustainability becomes a problem. If sub-counties were funding themselves to attend these meetings, I think sustainability would be there, and where we are not performing well, they would also put more effort. I submit. My name is Beatrice Chemisto, ADHO Ntungamo.
Thank you so much. Can we give a very big clap for all those that have participated in this section? And I know we are having more group workings, we are having more presentations. Whoever has not really had a chance, we shall have a chance up to the end of our day. Now, allow me to ask the permanent secretary, because she's the head of our all technical people. She's the one who helps us. The only issue that was for the minister was an issue which was about digitalizing health facilities, and the ministry to work with the Ministry of Energy. I only want to report that this issue has been coming out so often in Parliament, and the Honorable Minister has rightly responded and put the plea that the Ministry of Energy should look into this issue, especially where there is regular power supply to our health facilities, and even where there is power supply, the costs are very high. And we were made to understand in our last parliamentary session that at times they cut the power because they don't have money to run it. So we have brought even this issue to say that as a Minister of Health, the Minister of Energy ensuring that as they lead to other sectors, especially in the investment, that also power supply and ensuring that there is consistent power supply. So we are handling it with the Ministry of Energy, and the Minister promised that we shall continue engaging them, and we hope for the better. The other issues were raised by the Undersecretary. I now want to call on the Permanent Secretary. Most of the issues of staffing, infrastructure, vis-a-vis human resource, accommodation for the staffs, which everything is known, the issue of absenteeism and what the members have some suggested. You definitely were passionate about this. You have moved to acceleration of promotion of staffs. Most staffs not, the standing orders and the antigen and community health programs. Where some have not been answered, the Director General will come in, and my colleague, the Minister, will wrap on the discussion of this morning. So we are going to share between ourselves. The PS has got 4 minutes, Director General 2, my Minister 2. Finally, I will say 1 as I thank all of you. Thank you so much.
Thank you so much for those that raised the questions. I think there are a number of cross-cutting issues that we cannot answer these questions without other MDAs in the room. Ministry of Finance provides resources for human resource. So when we talk about staffing or financing for HR, it is very important to know that there are some other sectors that play this big role. Our role as the sector, we plan. We plan, we say we need this number of doctors, we need this number of nurses, we need this. But the other sectors as well, public service and finance, play a very big role that sometimes is beyond us. What we do on our side is to continue engaging and lobbying for the resources. And this is what we still will continue. And I think National Planning Authority is so central in making priorities very, very clear to Ministry of Finance. There are some things actually she talked about, like being in this one room and discuss the issues that are cross-cutting that we may not even talk about and come up with a resolution, and we do it without the other people. Teenage pregnancy and all other things, other indicators that we set, we cannot do without sitting in one table and each one committing to fulfill their role. Now, the staff absenteeism, still, it is in that line, that we cannot do this as the sector alone. How come I have not had people suspended and lose their jobs because they never work? You mean we have angels in this country? No, we don't. We have many people who do wrong things and they get away with it because of impunity that we have allowed to be entrenched in our processes, in our systems. Because government has got elaborate, very elaborate structure that can deal with everything, including monitoring, including supervision. The problem of absenteeism is that even the would-be supervisors that would be holding people accountable do not have the moral authority to discipline the other people, because they are also part of the problem. When DHOs do not know that the in-charge is never away, is always away. The in-charge does not spend time at the facility. And the DHO knows, but nothing is done. And when we go to the facilities and we ask, where are the warning letters, those so-called warning letters that don't make any sense to me? I have never understood those, let me not use the word. I have never understood those warning letters because they are meaningless. Meaningless. So what really we want to see is leadership in us. Rise up. Rise up. You are in that position as DHO. You are in that position as COW. You are representing the interests of the sector of the government. And therefore, to watch people who don't work and you do not do anything, that's where the problem is. When you don't report doctors who never work, who are always hobnobbing in places, and you do not report them, and you do not sanction them. We have so-called reward and sanctions. My goodness, I don't know what those ones do. So if we cannot take people to answer for their actions, if we cannot hold people accountable for what they have done, how can we now say, and we sit here and we just lament? It's not about, and I like what DG said. Today it's not about lamentation. It is about recommitment to go and follow up and make sure that people work. Those who don't work, they should be excused and say, thank you very much. We thought you were here to work, but since you are not working, please, in the interest of service delivery, we are going to get another person to do that. Why are we not doing it? Some we know that even because nepotism has killed our society, people, they rather stay with people who do not work, provided they are relatives of some people in the district. And those are the things that we need to talk about and we deal with. So for me, I think this issue of absenteeism, it is a big elephant in the room, but I know that with commitment, with determination, with focused supervision, go there and ask questions. The duty roster is there. Why is this person not on duty? Why? And then you must explain. If you don't explain yourself twice, you leave. You just leave. I don't know why we just babysit people who are doing wrong. So for me, that is the thing. And we need to see our structures work. The health committees, the health management committees, these are people, well, those ones really, I don't know whether, I will not want to criticize them, but these are just villagers, just there, coming, sitting, they just hear what the in-charge is saying, they have no idea, they don't know even what they are supposed to. That one, I don't want to go there. But we have an elaborate structure, the DHO, the assistant DHO, the in-charges, how can we not use that? So I think that is very, very critical. Dr. Nkoyoyo talked about lack of power. This is something that is continuously being addressed. Whenever we get support, we put solar in some of those facilities. That's why even the cold chain, we had to work with Gavi to make sure that they give us the cold chain, the fridges that are powered by solar so that we don't fail to get vaccines at all times available in our facilities. But this also, the solar is also limited. You find that they can only power, maternity or maybe theater. So what we need to see is more investment in sustainable solutions. And the sustainable solutions, one of them is to see how we can lower the rate for power for for the public institutions. And this one, we have raised this, but the discussion is there. The other thing is to invest more in solar, but bigger solars that can do more powering of the basic. But this is our agenda, this is our target, and we continue to lobby funders to support us, because in our budget we do not have money for the solar. So I think that is it. But as I conclude, today as we sit here, I want you to know that we are part of the history for our country. We are part and parcel of a solution for our Uganda. If we fail to do our roles in our respective capacities, if we do not see the importance of recommitting and creating more time, and not cheat government, but create more time to do the work for which you are hired or which you are voted, then I can assure you the history will judge us. That's the simple thing. So, in summary, I'm just saying, so many things have been said, so many things have been presented, but it's all about coming back to self. It is all about saying, what is my role? It is all about knowing, how can I make results? How can I deliver results in my area of jurisdiction? It is all about being innovative. When you are leader, the leader, it's not just the title. The leadership is about getting solution where the challenges is. Why up to now we are still talking about failing to attract DHOs in our respective districts? We just needed to sit, and I requested the Health Service Commission, Public Service, can we sit? And we resolve this. How can we fail to have DHOs? Because now you must be principal, you must have worked 9 years. It's not about 9 years. We have seen people of 20 years in DHOs, and they are absolutely that one I don't want to say. Absolutely So it's not about years. It is about capacity, commitment, etiquette, the skill to deliver. That's what we really need to discuss. So how can we fail as government that up to now 55 districts have failed to have DHOs because we are still circling around? Experience, 9 years. Is that really what we are here for? I think we need to sit together on the table, Public Service, Health Service Commission, and we resolve this so that we have DHOs in our districts. Exactly. So anyway, I think let me handle this.
Thank you so much. You have heard it from none other than the PS, and you could continue engaging her as usual. You all know that communication skills are the best, everything, and she's open to each and everybody. The Director General had already said what he wanted to say, but I am sure we want only to know whether his issues were satisfactorily answered or if he has something to say. Director General? Then we shall have our Minister of State, PHC, and the Senior Minister will conclude on the way forward and comfort us as we go home. Thank you.
Honorable Minister, I think most of the issues have been raised by PS. I'll just, answered. But she raised some issues also. I just wanted to make 1 or 2 more comments, especially regarding the supervision by our colleagues. Because when you find a problem in a district, in a hospital, me nowadays, the problem, I put it on the head of the institution. If I go in a hospital, a regional referral hospital, and the doctors are not working, the doctors are not doing ward rounds, you can't find the consultant, the challenge goes to the hospital director. It is clearly the hospital director. And we discussed this thing during the last review. and I hope there are changes. When we had our quarterly review, we discussed this thing in detail. I even told them of a story where one time, I don't know if we have anybody from a PNFP here, like a hospital director from a PNFP. Lacho, did I see Lacho here? I even told them, can you go to Lacho, and you are a doctor, and you spend 3 days without coming to that hospital. Monday, Tuesday, Wednesday, and you have not come. And you come on Thursday, and they allow you to continue working. Why do we do that? Why do we allow that in our own government hospitals? So the hospital directors, the senior nursing officers, you are the people to do those interventions. Otherwise, how do I go to a hospital? We have even been doing analysis. You find a senior consultant has done 2 rounds, 2 ward rounds in a whole month. Surely. And is now at 13 million, 14 million. You find a consultant surgeon has done no theater, no operation in a whole month. Surely. And I'm a hospital director? Me now, I don't blame those consultants. I blame the hospital director. So really, we need to address that thing. On the issue of antigens, immunization, if the ADHO, really, all the years I have known, the ADHO, MCH, we are so passionate about vaccination, so passionate about reproductive health, that ADHO, we realized that there are no vaccines in a health center. She will even refuse to work. She will even give rough time to the DHO. I have no vaccines in this place. The cold chain has no vaccines. These people don't have supplies. I don't know what has happened to ADHOs these days. They are so passionate. And if they were doing their job very well, we should not be seeing this. We should make sure that vaccines are delivered to every level. We should make sure that gases is delivered, and they would make sure that everything regarding vaccination and regarding reproductive health is in place. The health center force, I know challenges of anesthetist, but we discussed with you one time and agreed if you have no anesthetist, you come and we identify for you an anesthetist, and you go and handle with your district service commission. You can even trade off some positions and recruit an anesthetist, but surely health center force must do cesarean sections. We have also agreed on blood transfusion with our IPs. If you are an IP and you have a health center and has no fridge, and one of your mandates or objectives is to improve quality of services in your operational project areas. So what quality are you talking about? That you can't even buy one fridge to a health center for, and then they have blood to give to cesarean sections. You saw how many health center force were doing operations without what? Blood transfusion. So I really want to appeal to our IPs, and literally we have almost IPs in all these districts across the country. And we discussed this thing in detail even in HIPAC. Let's try and make sure that all our facilities can give blood transfusion. DHOs, your supervision is by the cow, but you also know that the cow supervises you on management issues. There are technical issues where you'll need guidance, where you'll need supervision, where you require technical guidance from the center, and you know where to go in the center. I rarely see DHOs there. I rarely see them coming. And one time, actually, Dr. Kware, who is even your colleague, a very senior DHO for many years, was assigned by the minister to take care of interests of all DHOs. I have not seen anybody coming to him and saying that I need guidance on this. I don't know whether you want it in writing. Maybe we can put it in writing if you want it that way. But technical supervision, you need somebody technical to supervise you. And therefore, you must continue to link up with the technical teams. We have not talked a lot about illegal charges because it never came out in the report here. But we must put in place mechanisms of addressing illegal charges in our facilities. And we know there are challenges in radiography, there are challenges in the lab. You may not get your results out of there without something going around. So as supervisors, we must put in place mechanisms to address some of these issues. Thank you very much.
You have heard the Honorable State Minister, PHC.
Thank you very much, Chair. That time I have been here, I've really noted so many concerns. But for me, I just want to warn us as leaders, because I can see leaders from all over the country, that we're entering a very, very dangerous time that will really take us back. Like people will read about us in history. PS said history will judge us. History will judge us for so many things in this health sector. The thing that really has been disturbing me so much are the teenage pregnancies. We are losing so many mothers while giving birth. We are having an explosion of numbers in this country, which is very disproportionate to our resource envelope. And sooner or later, because we have 15.7% young people, average age of Uganda is 15.7%, meaning everybody is young. The working class is less than 20%, I think 15 or something like that. So the burden of having all these children give birth before age 19 is a crisis, and if we don't handle it now, we shall have quantity in numbers, but no quality population. It has to be handled, because I don't think everywhere I go, I find children in hospitals. Yesterday I was coming from Hoima, children in every hospital, children having babies. It is a crisis. Since we have very many of them, we need to find a solution to this. I know it's parents. First of all, it starts with parents talking to their children. The other issue, everybody has talked about it. That's why I don't want to dwell on issues that you've been discussing for these 2 days. The apathy and attitude of our health workers in local government facilities. I don't even know what to say. But it's so disheartening to go to a hospital with a workforce of 48 people, but there's only one person on duty in broad daylight on a working day, and everybody has an excuse for not having come to work. It is so sad. Those that I would find, and they call each other when you arrive, because we're making impromptu visits. They call each other, and by the time you leave out of 48, after 2 hours, around 10 will have come. I tell them that, people, look, while you don't come on duty, you do not control where your kin and kith go to hospital. Your mother, your sister, even your own child can be taken to a health center and there's no health worker. You are not doing this for yourself, do it for society, because karma will catch up with you one day. And you will pay. So this community engagement is one of the things I wanted to talk about more here as minister in charge of PHC. Community engagement is very important. Sometimes people are lost. Parents are lost in alcoholism. Then there are no peer society members to talk to the children. The crisis is big, but as a health sector, we have a very big burden of, first of all, non-communicable diseases, preventable diseases. All this goes back to the community engagement. We need to up our speed in community engagement and information to the public so that we decrease the disease burden, end teenage pregnancies, HIV and AIDS. Yesterday I went to an art clinic and I was shocked to find a number of children born with HIV. And they were talking about discrimination in school when people get to know their own drugs, because they have to take a drug at some point. It's so disheartening. We need to go back and lead us and leave a mark. What will people say about you when you wind up your time as DHO in a district? You want people to celebrate your exit? Please put in a lot of effort. These are the jobs we have signed up for. Let's do them with passion and compassion. Thank you very much.
Thank you so much, everybody. There is someone who has been on online. If we can try ICT, if we can catch up with the participant on online.
Yes. Can you hear me now?
Yes.
Yes, thank you so much, Chair, Honorable Minister. My name is Dr. Ekwaro Obuku. I am the former president of the Medical Association, and I'm sitting here in this capacity from Loro City. Loro City is just near Lira City, where my very capable MP, I can see her there. I have 3 critical areas to address. The first one is the issue of supplies. And because of the idea to provide solutions, let me make proposals. Why don't we improve the competition for the supply, the purchase and supply of these supplies? We spread this money, give it to JMS or other private players. Because I was here burying my grandmother, and I was blaming the staff for absenteeism. And the medical workers told me, Obuku, what do we do when 4 cycles have not come? So really, we need to privatize the procurement and supply within the budget, and I'm sure we will see results. The second issue I would like to address is the issue of absenteeism. And I'll make a proposal. Yes, we solve the problem of salaries, but the next big problem is the problem of absenteeism. I'm always quarreling with my doctors when I move to the field and I see them not there. There's a lot of nepotism, and that cannot be solved without cracking down on the recruitment process. Why don't we re-centralize the recruitment? Secondly, why don't we give performance-based contracts? I saw Dr. Agre there, Bameka. He presented that in one of those districts, they did performance-based contracts, and it reduced, he said, it reduced moonlighting. Salaries were tripled. That alone should have reduced moonlighting. I think the permanent secretary of Ministry of Health and permanent secretary of local government and the permanent secretary of Ministry of Public Service should be serious to ensure that this thing, there is a change in the public service standing orders to contract workers rather than use the issue of what is happening now. I'm very disappointed. We fought for these workers, but now they are really disappointing us. I've forgotten the last point, but if I remember it, I will mention it, because I had to log off. I'd written down my points online. Thank you so much, Madam Minister. I'm very happy to see you. I'd never seen you in action, but I saw you are chairing very well, and I shall be coming to thank you in person to your office. Thank you.
Thank you so much. Thank you so much for campaigning for me to be chair next session. But I have to, now we are calling in, it's time for our minister to wrap up on our discussions. I only have one issue from Dr. David Okino, DHO Kwania. His issue is about the ambulances being concentrated at regional referral hospitals, and is asking why not at the districts as coordination centers for quick response. Madam Minister, the question is saying the ambulances, why should they be centered at regional instead of at centers, which are the districts? And Kwania has got no single government ambulance. That one I don't know. Now, Honorable Minister, it is your turn to wrap up. You have seen, we said we are moving from lamentations to hope, and with your last word, I'm sure we shall go out of this room with much hope. Thank you so much.
Thank you very much, Chair. First of all, I apologize that I missed the presentation. I was trying to work with my secretary on a cabinet paper for Monday on phone, because I am here and they are back there. I will respond to a few issues. I think let me start with the ambulances. First of all, if we are to give ambulances. Yesterday I said in my opening statement that the local governments are abusing vehicles. And my PS is going to withdraw all the pickups, by the way, for your information, in not very long future, very near. All the pickups will return for the one who bought them to inspect them. And you know the one who bought them. Because we are seeing what is happening. It is not that we are blind. Ambulances are given per constituency, not per health facility. So don't even think that a health facility will get an ambulance. This is the policy of government. The only health facilities that get ambulances are regional referrals, are specialized institutions, and the tertiary ones only. And we are moving away from just giving them the type B to giving them type C, the specialized ones, because they serve regions. But the rest, it is per constituency. And we shall start with constituencies that have never received. Even the ambulances you have will move away from the facilities to constituencies. The facilities will only host, because they can't be left anywhere in the night. They will host, but they will belong to a constituency, and they will be manned through an ambulance call center, which will be based in the regional referral hospitals. So, don't cry for ambulances. The National Ambulance System already has a policy and a strategy, and they will be informing you accordingly. Your duty is to have an ambulance team in place and a leader for that ambulance team, so that the ambulances can serve the entire population, not a few people. That is what we are looking at. Now I want to talk about supplies. I had Obuku. Earlier on I had a presenter of mine talking carelessly that NMS has this habit, and I wondered whether some people are leaders. The whole of last year, we struggled with supplies, right from the time of COVID. And I thought that all of you are aware, because Ministry of Health and partners are aware about the situation. Because NMS used to have a system where they had money running all the time, so they could take supplies to the districts. Now they don't. That system was blocked, and they have to request for money through Ministry of Finance. Imagine requesting for money for drivers and requesting for fuel through Ministry of Finance. And then you wait until the money is sent. So they can't send the medicines. That's why medicine delays 3 months, 4 months, and then it goes all the quarters together. Even Parliament got concerned. We had a long discussion in Parliament, and a recommendation was made, put NMS back to its former system so that they can send medicines. But up to now, it has not happened. They are struggling. Imagine if for you people, you wait for money and money doesn't come. But now this is a supply chain system for medicines, and it is supposed to undergo the same system through which you go. You can imagine the frustration. So stop blaming NMS. I hear people saying, we should give money back to the districts. You know, I was in the district before, and I was a hospital director. So all these things I know, and I want to educate Obuku. In those days of ours, money for medicines used to go to the districts, to the facilities, and were free to buy. You choose either NMS or JMS or your pharmacy in anywhere, you are free to buy. Very few hospitals, including where I was, were buying medicines. The rest would go and get pro forma invoices, eat the money. So the hospitals had pro forma invoices, but no medicines. That is what led to re-centralization. And we have put in effort as a health sector to empower the national medical systems supply chain, together with partners. Now we have all it takes. We have only one loophole. Finance has to realize that you cannot treat the health sector like other sectors, because it is a matter of life and death. So instead of blaming NMS, you should rise up and complain. Why are you treating us as if we are selling tomatoes or whatever? We are dealing with life and death. Open the system so that medicines can come. Lastly, I want to appeal to the local governments. Yesterday I talked about accountability. When I came in, I found the PS talking with a lot of passion about work. The truth is, the local governments, my DHOs, the cows, the chairpersons, you have gone to sleep. You have seriously gone to sleep. Our attitude, our mindset is completely gone. We don't even care about life. Everybody thought salary enhancement would address the issue. Personally, I stood up and said it will not address the issue. It is like we have lost nearly 5 generations. There are places I have gone to and have not even seen a DHO. I live without seeing a DHO. Now people are asking for ADHOs to be gynecologists, to be surgeons. I think this is wishful thinking, really. A whole gynecologist who is supposed to be in theater doing specialized services, going to vaccinate, to do programming for vaccination. What is wrong with our minds? A whole surgeon who is supposed to be handling tertiary care of all of you when you break your legs, do what? Now, as a ADHO, running to a health center 3 planning for vaccination. What is, even the people who muted the idea, surely, you should be ashamed of yourselves. What is that magic bullet of being an ADHO? We took a decision as a country that we want as many public health experts as possible. That is public health work. It needs community mobilization. It doesn't need a specialized skill. It needs a mobilization skill, a planning skill, a managerial skill. You go and do the work. So let us stop trying to confuse ourselves. Yesterday I hinted on one thing. I said, in the book of Genesis, God made all of us leaders. So we all have the leadership spirit in us, but we lack the spirit of leadership, which is our attitude, our mindset. Everybody just comes and thinks, what will I get out of here? How much money can I make out of here? How much time can I spend here? 30 minutes, then I'll run and do my private business. We have to get back to the point when we say, our country first, our people first, our health first, and I'll stand in for it. I saw that attitude in Ethiopia. I haven't seen it in Uganda. And yesterday I said, until our attitudes and mindsets change, we are not going to develop. And I can see it still rotating here, the wrong attitude and the wrong mindset. It is here. And some people are saying, let her talk. They talk every day. That is still the same attitude and mindset. The question that you will be asked, you were there. What did you do? when the recruiters don't do their work, or they recruit for us substandard people, they will also answer. And by the way, the other accountability is worse than the accountability here. The other one, there is no appeal. Here you can move around, you can go and confuse the DPP, you can go and bribe the auditors, but up there, you will know when you get there. God bless all of you.
On that note, that when you go there, there is some appeal. We anticipate that by the time we reach there, we should have become the right people, righteous, and when we reach there, we are very righteous, and the God will listen for our appeal. Can we thank the Honorable Minister, the Senior Minister, for her wisdom, the words of wisdom, the words of encouragement, the words of spiritually wishing us all to reach there where we are not going to ask to be forgiven, but we go as forgiven people. We would have continued, but everything has to come to a program. That's why we have strategic planning, and that's why we are here to review and see how we can move together in this joint review. I know our sugar levels may be asking for a cup of tea. Our next is group formation. So I wanted to find out whether we could have these group formations after break tea, and then another chair comes in as we go to the thematic groups and go with our next program. We are late 1 hour and 15 minutes. We have tried our best, but allow me to thank all of you. In this room, we are partners and we are a family. And when we are a family, definitely there are things that are times don't go on, but the passion you have seen in this front desk and everybody, we are partners in the health sector, and no one can do it on their own or on our own. We are in this together. Dr. Jane has said that when you go, they will not ask about where is Jane. They will ask, what was your contribution? What was your input? What did you change when you are in the health sector? I only pray that we continue working together. We find the solutions where we find the hurdles. And at the same time, leadership and governance. When I came in, I was so enthusiastic to go to our health facilities. The PS can testify to this. I spent like 6 months every week. But I think you have not seen me in the last 6 months again. You reach some facilities, from all here to the way Guru. The only person you can find, not even a sweeper. Regional referral hospitals. You find your own staffs are working in like 3 different facilities, monolighting. And when we are talking about service delivery, let's not talk about DHOs not knowing where they belong. This one is not there. Can we start with our facilities? Can we start service delivery within our facilities? Even if I had any means to go to where you people came from, I would find nobody at our health facilities. Leadership. I did not know that leadership comes from the book of Genesis. For me, I've been in leadership for some few years, 20 to 30. I thought it's a struggle in leadership. Let me go and read that verse as I hand over this mic to some other person. Thank you so much. We clap for ourselves. I have enjoyed chairing you. I'll continue when I'm given an opportunity, and we continue sharing. We are in this together. We are not pointing fingers. We want to improve. All of us want to participate and contribute. I thank you so much. My senior and my sisters, the PS and DG, thank you so much. Under Secretary, we shall continue working together to ensure that we make a change in the health sector in this country. Thank you so much. MC Dr. Kwari.
Thank you very much. Let's formally now appreciate the Honorable Minister. You have chaired the session so well. We appreciate that from you. And we also appreciate all the other members of Senior Top for this wonderful session. Now we go for coffee. It's late. It's already, isn't it, midday? Let's spend less than should we, because after break we have group work. The Honorable Minister is of the view that we introduce the group work. We divide ourselves into the groups, go for coffee, and after that we just come back and start the group. Eh? Let's go for tea. Okay. Okay, so let's go for coffee. 20 minutes this time. Yesterday we gave you 30 minutes, but you did very well. You came back in 20 minutes. Yes. Okay, let's say 30 minutes. Coffee is downstairs at the tent, at the garden there. 30 minutes, 12:30, we are back here. Thank you very much. Double the time. Because we shall still come back. We shall still come back to present. To agree. Present and then again agree.
So these are the groups that were supposed to be. Yes. Why don't we leave it
First the brainstorm.
Because we want them to own this.
Own.
When we get people to talk anyhow,
Then some people choose not to talk at all. The only thing is time. But now, Sarah needs to identify the group chair strategically. Biasing them to the areas where perhaps.
No, this man, never see him active in these things.
Now we are going back to groups. But now, can we identify the chairperson?
So how are you going to break us into groups?
We'll get one lead person. And then we'll
Like
say,
here, human resource.
so that we'll place them what? Place them in
Exactly, that's what we want. That's what we wanted to. Sir, how are you?
Okay.
How is the day?
It's not bad. And how is it?
Because she doesn't know what I want.
We have our original one.
For me, I want
You people failed.
I mean, in
You failed to organize. But it will still go on.
at least we have seen how it is.
Yes. You failed. Okay, ma'am, thanks.
something like croissant. Yeah, but just a one croissant and some fruits only.
This is a croissant.
There
is
no croissant. All what is there.
Help to notice.
Okay. Whatever is there, there is some pie.
Pie.
Only this is a croissant. Only this. Only. Have you seen what you are going to bring? Only these two. This one.
Hey, there was that.
Which one? But it's also you have them there.
What is that thing called? The capret sim.
Oh, this one, it has cheese.
Give it to me. We can swap.
What's wrong with cheese? Also, you fear cheese. No, I don't fear it. I eat it. Don't give me more. I take your cheese.
I'll take the cheese very well with one hand.
But for me, I want to organize a prayer we prepare the good, then we launch it, and then we do, then she gets it. She doesn't sleep at night. Then I'm not from the NSS president. What? But even with this thing, she did the same. Even in the she has been doing this and we've been seeing over from. And you say I told him that you want to, but this is too. He asked what is your problem? I said no, this has some things she wanted to consult you about. So when you get a moment, you call her. I said okay. Well, what?
Good morning, ladies.
Hi.
Good morning. Good morning. How are we? Very good. We're excited about the digitalization pre-conference visits. We're ready to go
Ah.
see some of the
Hello? Colleagues, can we get seated and we start our session? I hope you enjoyed your coffee. Hello? Dr. Sarah, I hope you are ready. Members are ready and they are waiting for guidance on what work to do and how to do it. In our program, if you have a program, look at it. The guidance is there. We are going to go into some small groups, about 7 groups or so. And there are various topics or areas that have been flagged. This has come from the discussions that we've held since yesterday. So we just want to have a deeper discussion on these areas and get consensus. So we shall project the areas for you, and I think there are printouts that are being prepared for you. We shall give you 1 hour or slightly less to discuss, and then you come back and present. Then we can, as a team, agree on what actions to address the issues that you have discussed. And our chair at that point, when we are discussing, will be Dr. James, the Director, Regional Referral Hospital. He's already here. So Dr. Sarah, we're waiting for you. There will be a group that will discuss issues surrounding NCDs, non-communicable diseases. And you recall that we discussed this a lot since yesterday. There will be another group with issues that have been summarized, but around communicable diseases. That's group number 2. There will be a third group discussing issues around reproductive, maternal, and child health, MCH, including teenage pregnancies. We want solutions, workable solutions, to address the issues there. Now, that's group number 3. Group number 4 will discuss community engagement strategies. How do we engage the community better? It's an expensive undertaking, but we want to hear from you as stakeholders. How can we do this with the little resources that we have? Because this is the way forward. And group number 5 is around human resource, improving skills mix. Again, there is a detailed paragraph around this for you to discuss. So that's 5. Number 6 is health financing. Number 7 is quality of care, so that we can reduce all forms of inequality as we provide our services. So how many are there? 7. So those are 7 groups. I want to believe that, Dr. Sarah, you're not adding another one. We have 7 themes. So I want to get volunteers to be like the standing posts for each of these themes, so that the rest of us can now choose where to go to, depending on interest, and level of knowledge about the area. And if you have any unique innovation that you think you want to share with that group, you can choose that group and you can give your ideas. So can I get 7 people? Volunteers, you can come. 7 people. By show of hands. So, okay, you come. Come.
7 groups.
NCDs, quality of care, health financing, improving skills mix, that's human resource issues, community engagement, reproductive health, communicable diseases, and non-communicable diseases. Okay. Community engagement. Okay, come. So which one? Quality of care. Human resource. Community.
So I think we shall.
So community engagement stand. NCDs. Communicable diseases. Oh, NCDs. Dr. Lwabi, thank you very much. So now gender. We need the gender. NCDs is already here. Dr. Lwabi is there. Okay, now I think you can choose a suitable corner of the room. Just choose a corner. These are 7 groups. Where are you going to sit? No, you'll stand. People are coming to join you. Yeah, choose your. Yes. Some can go at the back. You can move the chairs, don't move the tables. Community engagement. I have not got someone for communicable diseases. Please, can we have a lead? Communicable diseases. Communicable. Okay. Okay. Okay, so now when you reach there, the members are coming to join you, and then you organize your seats. You can just move the seats alone. Don't move the tables. And then you choose a chair and a rapporteur. And you start the discussion. We shall give you a detailed description of the problem in that area. We are giving you that one. A detailed description of the problem that you need to address. Yes. So choose a chair and start. So can I request everybody to stand and move? Everybody stand. You can move with your valuables, your phone, to a group of your choice. If there is any group that is not very popular, we will request a few people to move there. So we give you 5 minutes for the movement and then you start. We time you. Thank you. So meanwhile, I introduce to you the chair for the session, feedback.
Ladies and gentlemen, kindly organize yourselves as quickly as possible because we are going to give you exactly 45 minutes And you know, it is being chaired by the Archbishop. So you better handle it as quickly as possible. Mass is always said in time. Is that okay? Can you organize yourselves? 45 minutes. Ladies and gentlemen, organize yourselves and start. Make sure you choose a chairperson and a rapporteur. A chairperson and a rapporteur. If there is a team which is very unpopular, we can add for you more people. NCD is good. Which team is this? Reproductive health? Reproductive and maternal health seems to be very, very organized. We want to, oh, maybe ADHOs, but ADHOs should also go to other areas because they're involved in HR, they're involved in community engagement. Human resource, I saw somewhere in the middle there. Yeah, this is reproductive and maternal health is here. Community engagement is on my right. Somebody is looking for HR. Where is HR? Improving skills mix. Center left. Huh? I hope in politics you know what center left means. HR is in center left. This is reproductive health. Can we start the discussion? Can you lessen the talking? Can we lessen the talking and we start the discussions, ladies and gentlemen? Which group is this? This is communicable.
Yes.
Yeah. Pardon? Oh, do you have this? That is number 2, so you look for number 2. But that is mine, eh? It's mine. Sure. Sure. Ladies and gentlemen, can we lessen the talking? Can we do the work? No escaping out. I'm going to close the door. No escaping. Last left is what? Which one is that? Quality of care. Extreme behind. Yes.
Members, quality of care is looking for a female participant. Quality of care. Good.
Can you give me back my microphone? The quality of care is extreme left and last. So, ladies and gentlemen, can we reduce the talking? Can we start work? Yeah, thank you. Yeah, thank you. Yes, I'm on HR. Okay, yeah, that's very good. Get your place, please.
I'm trying to see which is not.
There are some teams which are oversubscribed. And settle well. Eh? Sorry. Yes. Please choose a chairperson and choose a rapporteur. NCD is just NCD is here. Yeah. No.
We are timing from now.
Yeah.
You give them 45
Ladies and gentlemen, I'm timing. The Archbishop is going to start the Mass. Once I say the Mass is ended, please, you close. 45 minutes. Where is NCD? Somebody is looking for NCD. NCD is extreme end. Yes. Okay. Excuse me, kindly give me my.
Yes, we are moving on with the introduction.
Thank you.
What about the thing taking you to Kalangala as well? Kalangala as well.
Good afternoon, ladies and gentlemen. Honorable Minister, all protocol observed. We are going to start our presentation, and we are giving you strictly 7 minutes to present your issues, the action points you came up with, and then I hope the Secretariat, Ministry of Health, you will pick up what the rapporteurs have put in writing. Can we sit down, please? Attention, can we sit down? We are starting the presentation. The first team to present will be the group for NCDs. NCD, I hope you are ready. Yeah, if you are ready, kindly present. Be to the point. And we are giving you 7 minutes. The presentation will go like this. The first 4 groups will present. Then we shall have a reaction to that. Then we shall take the remaining other 3 groups. Is that okay? Kindly pay attention so that we finish in time. And I'm going to be extremely strict when it comes to time. Thank you. NCD, it's your turn to present.
Good afternoon, ladies and gentlemen. My name is Kampumza Davis. I am a nurse at Chirudo National Referral Hospital. So I am going to present on behalf of Group 3, that is NCDs. So we had we had about 4 areas to discuss. We are sorry, the chair at the time was not enough because we had very sensitive issues, but we tried to work in the time frame that you gave us. So as we all know, NCDs, the mobility and the mortality of NCDs has actually increased over and over, and it's actually expected to go even above that of communicable diseases if we do not take the initiative and we fight the NCDs. So our first area of interest was on cancer screening, that is cervical cancer, breast cancer, and prostate cancer. So our causes for the information on cancer screening, number 1 is that there are no guidelines for most of the cancers. For example, prostate cancer, breast cancer, they are not captured even in the tools that we use. So that has actually made it hard for us to have the information on the cancers, and thus it becoming a gap. Second is that there is no tracking system. That is, we do not have a tracking system of the age, maybe the rates, the incidences, the mortalities, and more so the systems that are there actually lack the reporting system. So in the end, we actually end up failing to have the information about the cancers. Our other cause of the gap was lack of information, lack of awareness among the populations, and also the health workers. So most times people in our communities are sick. They don't know what they are suffering from because they are not aware. And also the health workers in our communities also do not know how exactly do some types of cancers present and how to distinguish them from other diseases. The other challenge was that our health facilities, most of them do not have screening kits, that is, the screening tools. For example, kits for prostate cancer, breast cancer, and cervical cancer. So this has been also a gap, and therefore, since we do not screen, then we cannot have information on these cancers. Our interventions to mitigate these gaps, number one is that we as the country, especially the Ministry of Health, need to create awareness campaigns among our communities and also among the health workers so that we can try to bridge the gap of unawareness. And then also we can also try to, we got actually another intervention from one of the members from the information system from the Ministry of Health, who told us that there is a revised data collection tool for these cancers that is actually going to be capturing most of the cancers and also other NCDs, and also report these NCDs, and this tool is going to be out by the start of July 2024. So that is actually a good one because it even gives us the timeline that it is actually going to happen. The other intervention is to orient our health workers and train them on the different kinds of cancers, and we give them knowledge on how to handle, that is, screening, diagnosing, and also treating these cancers at their various health facilities. Then there's also the last one about cancers is that we need to develop a comprehensive policy. Of course, first we start with the guidelines, then we come up with policies, and we could incorporate these policies with those of the Uganda Cancer Institute so that we can have the policies for these different kinds of cancers, that is breast cancer, cervical cancer, and then prostate cancer. So that was our number one area. Our second area was about road traffic accidents and death related to road traffic accidents. So you realize that actually in the recent years, the road traffic accidents and related deaths have actually risen, and these are one of the causes that we have discussed as the group. Number one is that the infrastructure of our roads and other transport networks is really not good. Some roads do not have signposts to guide the road users. Other roads are really in bad condition that they actually increase the chances of accidents. Then others have potholes. Others maybe have been closed and they are too narrow for the big traffic to depend on them. And then the second cause is that most of our drivers and riders are very reckless. They drive without responsibility. Others drive under the influence of drugs, alcohol, and so on. The other cause is that our enforcement authorities, for example, the traffic police, some of them are corrupt, and this has costed us a lot as a country. There have been cases that have been given that actually some drivers and riders actually know that they are in a wrong, but go ahead to go through the traffic points through the corruption and giving the enforcement authorities some handouts. So as a group, we really cited out that that is also one of the causes, because if let's say an example, a taxi driver who is carrying about maybe 20 passengers, but instead of 14, does that on a daily, every day. So we don't know what happens the next day because they are already overloading. Lastly, among the causes is that we have a lot of political interference, and also the commitment from the political side is really not enough to help us mitigate these causes of road traffic accidents in our country. So under the mitigation, we suggest that we activate a tracking system for vehicles and even the drivers, including the riders, so that we can take a good track of these machines and people, so as we can limit the road accidents. The second one is that the enforcement authorities should be regularly trained and well equipped with ethics on how to handle their duties responsibly so as to reduce the risks. The other one is that we need to train our drivers and riders adequately enough so that when someone gets on the road, they are well equipped with the skills, and also this can help us to reduce on the accidents. Then the other one is that we also need to train our drivers and the riders on the roads, the basics or basic life skills. For example, if an accident happens and the other drivers and riders gather at the scene, we do not expect them to keep looking at the victims. So in the meantime, as they wait for the ambulance and the responsible people, they can also do something. They can also try to provide the ABC, you know? Yes. The last one is that we can still activate our emergency systems. For example, the ambulance services to always be alert to avoid delays in case these accidents happen. Then we do not need to go ahead and lose lives. If they're there in place, then we can have these lives saved. And then also we need to reinstate the previous tracking systems, especially the one we know, Kawunyemu. So when it was being done, I think there was a great improvement. So our last one is alcohol consumption. The causes of alcohol consumption, we suggested that there are no policies that enforce operation of bars and all the businesses that deal in alcohol. There is lack of awareness among people about the effects of alcohol. The other cause is that there is a lot of depression and mental illness, especially among unemployed youth, and therefore they end up resorting to alcohol so that they can maybe solve part of their stresses. So the interventions here, we can try to increase the tax on alcohol. We can also put very strict policies on the operation of bars and other businesses that deal in alcohol. And we can also increase the prices of alcohol and also provide a standard for these alcoholic drinks. And then we can also increase awareness among the population about the effects of alcohol. Then lastly, we can still reinforce some of the policies like Kawunyemu so that we can limit alcohol consumption. The responsible bodies, the Ministry of Health together with the government, the civil society, religious leaders and religious bodies, the trade and tourism industry, especially with the part of alcohol consumption, then community, engaging with the community, and then all the non-governmental organizations. Thank you so much.
I'm going to change the rules a bit. The chairman has no seat. The chairman is supposed to be in the middle. So you will come and present from here. Is that okay? Yes. So the moment you leave that chair, it is not going to be yours again. It's going to be mine. So the next is communicable diseases. We're moving from NCD to communicable diseases. Communicable diseases, can you come and present from up here? Chair, communicable diseases, can you, this time I'm going to be very strict with time, 5 minutes.
Thank you. I'll represent the communicable diseases team. Just looking at the few indicators we had to discuss. One was on increasing the malaria and TB, the increasing malaria and TB incidence rates. And some of the challenges we identified, one was on the inadequate prevention information that is out there. We think that we need to provide more messaging for the population on the appropriate prevention messaging that we ought to put out there. Two, there is still a low risk perception for diseases like malaria, but also for TB. And three, we think that there are also a big number of asymptomatic TB and malaria cases that are out there in the community, and if not identified, we will not be able to do the prevention. So we propose that, one, there should be enhanced messaging for prevention of malaria and TB. If we have to think of new innovative approaches to deliver this message, then we ought to do that. Two, we need to sustain the CAST Plus campaign for at least 3 years consistently, be able to identify these cases and be able to treat them. Then we should be able to do the adequate prevention. But also a multi-sectoral approach. There's a lot of, approaching the community using the disease approach instead of a program approach. But if we looked at, the disease as one that needs to be tackled with a multi-sectoral approach, then we should be able to deliver on the prevention that we need to do for those diseases. Two, looking at HIV-exposed infant testing, where we have 91% of HIV-exposed infants getting DNA PCR within 2 months below the target of 95%. We think comparatively, we've moved from about 72% to 91% in 2 years. So by far, moving this target in 2 years from 72 to 91% is a big achievement. However, we think there is still opportunity because the EPI-EID integration is still wanting. And we also see some challenges with access to testing services, but also some health worker capacity gaps. So we propose that we increase the access to EID testing services using the point of care technology. Two, EPI-EID integration at all immunization activities, not just the immunization, designated immunization points, but the activities themselves. Every outreach, make sure there is integration. But also continued capacity building of health workers in EID screening, but also sample collection up to the level of health center too. Then general decline in ART retention at 12 months to 77% in Q4 against the 95% target. One, we think that there is a very big challenge with the data because we see a lot of movement of clients moving from one facility to another. They do not declare the movement, and so we are unable to track. You get medicines here, move to point B, get medicines next time. At point A, we think you're lost. At point B, you're a new client. So that is one of the challenges. Two, we are looking at differentiated service delivery models that we are emphasizing. Can we ensure that these are the preferred models? So client preference to the differentiated service delivery models. But also, we continue to address issues around the counseling that we have. So we propose that one, if we can get unique identifiers on board and we are able to track every individual client and the services they are receiving, and also make sure that with the digitalization of these services, the EMR is interconnected so that the health workers can be able to track just the services the client is getting as an individual. Then also document occurrences like the mortalities so that we are able to make sure we track this. The low viral load, we didn't think that we have a low viral load suppression. By far, our viral load suppression stands at 94% against the 95% target. So we think we should keep doing what we are doing to stay up there and even exceed the 95% target. So if we sustain the interventions that are running, we will get there. Lastly, on DPT-3 coverage, in some regions we had very low DPT-3 coverage. One of the issues that was identified is limited access. We think we also have data quality issues, leadership challenges. Leadership is one of the things that we think is affecting immunization access. We also have facilities where we don't run immunization daily. They have the facilities, but the activities don't run daily. So we think if we improve supervision and monitoring of these outreaches, we clean the data, and we address the issues of leadership, including, of course, the supervision, we should be able to get there. Thank you very much.
Thank you very much for being in time, and kindly sit nearby. Don't go far. The next is HR skills mix. HR skills mix. Please keep to time. Ladies and gentlemen, note down what you want to ask.
Thank you, Chair. I'm Dr. Gilbert DHO Kabale, and my team was chaired by the Kao Chiruhura. And the members, you can raise your hands on my presentation. Those were in my team. Thank you. Ours was HR, or skills mix. Issue number one that we identified was management skill gaps. And here we saw that the possible cause that health practitioners, in their basic training, they focus on medical technical skills and not necessarily management skills. recommend that you provide or utilize the accelerated promotion to be able to fill those positions. On one structure fits all, there should be flexibility for local government managers to deploy according to need where there is justification. Thank you.
Thank you very much, Skills Mix, and thank you for being within time. Please keep on noting them down, what you want to ask. The next is community engagement, the last one. Then we shall listen to your issues. Thank you. Community engagement. Thank you.
Thank you so much, Chair. My name is Mulumba Matthias Suna. I represent civil society on HIPAC, and I come through the malaria coordination body called UCAM, working with an organization called CEPAD. I'm glad to have had a chair who is also the chairperson L5 of Yumbe. Please, Chair and members, you can wave so that the questions come to you after. Members of my group community, I don't see you, including Minister, Honorable Minister. You're most welcome to listen to the presentation and questions. I'll be brief, I'll be fast. We had mainly 4 issues identified, and the first issue was unmapped community structures. And the possible causes are that mapping is not a priority yet with many stakeholders and partners. There are inadequate resources to do the mapping if we're to do community mapping, and there are also hidden and unknown community structures. The proposed mitigation interventions, one is that we should prioritize and allocate resources for mapping, because we need to know who is doing what where and how they're doing it. Then we need to build the capacity of those who have been mapped, because they are already those we know, but their capacity is not good enough. Then we need to innovate on indigenous and local resource mobilization for community structures, because we know some of these structures were living without the funding that we are looking for with the funders, but they were doing a lot of work at community level, including our mothers, Muno Mukabi, and others. They were not funded, but they were doing a lot of work. Then we need to fund the implementation of the community health strategy. Dr. Upenso is here. We are struggling with him to make sure that the community health strategy is really implemented. But we are already in Entebbe discussing to see how it is financed. That's another issue. We may have it. We have so many beautiful policies, as we always say, but their implementation is the issue. Who are responsible? We think the DHO, of course, Ministry of Health at the top, but a district DHO, CDOs, the political leaders, the CSOs, IPs, the religious and cultural leaders. And we think this is a continuous process. We don't have a timeline specified for that. And at the end of the day, we expect to have very strong and active and sustainable community structures. But also, on the other hand, the discussion we had here was that we shall reduce on health spending when we have the communities in charge of their own health, because they'll be able to even go ahead to prevent some of these diseases and ensure that we don't have spending on them. Therefore, we shall save the budget for other important issues. The second issue identified was poor coordination of community structures. And the issues, the problems, and the causes were uncoordinated partners with top-bottom planning. There are complaints at district level that partners will go straight to the communities, sometimes not even consulting with the district leadership. There's lack of joint planning at different levels. People will come and have a lot of uncoordinated but also duplicated services. There's limited transparency and accountability among partners. Yes, many of the partners, even at district level, are expected to report what they have in budget, but also account, but this is not effectively done. Partners limiting their scope to operations, which sometimes are not even aligned to priorities, both at national but also at local level. somebody will come with a donation and say, for me, I have to work on ABCD without even consulting. And then limited engagement of civil society organizations. Yes, in health, we are doing a lot in HIV/AIDS, in engaging civil society. But some of us who are in other spaces like malaria, we are starting, Dr. Pigo is around, but we are starting to see how civil society can get on board. But also other diseases. How do we get, because there is a lot of wealth in dealing with civil society. Then the other one is inadequately facilitated community structures. Those are the causes. But remedies we proposed that we need to agree on the roles and responsibilities of each of the stakeholders and partners through joint programming and planning. Of course, we have the planning processes that we go through, both at national but also at local government level. How do we get all the partners to come in and contribute to this process? The other one is that we need to innovate on the indigenous and local resource mobilization for community structures. Some of us are into spaces of local philanthropy, and we have done it somehow for us who are in Uganda, where the king sends us out there to look for resources from the people themselves, and sometimes the philanthropy works. In Uganda, we're not doing it very well. Kenyans do it very well, but we need to do a lot with local philanthropy. The other one, we need to enforce policy, guidelines, and legal frameworks, because these are already in place, and we think we can achieve. Then meaningfully involve the civil society, and then provide right, user-friendly, and timely information. This is important. We need to harness the digital information processes and technologies. We are happy that we already have a strategy with the ministry about digital, so we need also to implement it and facilitate it and give resources for the same. We need to promote multi-sectoral programming and integration. This is what we have always cried to. The responsible offices, of course, we go back to the ministry and all the other cadres that I mentioned, and at the end of the day, we shall have a vibrant and a functional, well-coordinated structure at community level. The third, and towards the end, is that we have non-attendance. This has been raised by my former presenter, non-attendance to duty by health workers. We also identified it as an issue for the community because the communities don't benefit a lot from that. So, and we said the issues, some of them have been mentioned, poor supervision from superiors, then the health workers' mindset, apathy and attitude. This has been repeated so many times. Then lack of patriotism is another one. Then the multiple jobs that people have, including moonlighting. Then the bureaucracy of handling and disciplining public officers. Some of these have been spoken to since yesterday. And then inadequate motivation of some cadres of health workers. For example, those who don't have accommodation and they live far. How do we want to improve this? We said let's contract health workers. Let's improve mindset of workers through different engagements. Let's have community dialogues. Let's have balazas, scorecards, community watchdogs, and others. We are good at that, Dr. Lydia, you know, as CSOs. So we need to really support and monitor the processes so that the health workers can provide the right services. We need to create more platforms for feedback. This is one of the platforms annually. But when do we get the other platforms to give feedback about what we find on the ground? Then we need to do continuous reviews, supervisions, and assessments, targeting, rewarding those who perform better, and probably punishing those who don't perform. And the other one is about motivation of workers. Yeah, at the end of the day, we shall have regular attendance. We shall have effective and efficient health workforce. Our last issue was about poor information packaging to communities. And we think this is caused by language barrier. We have a lot of material, especially in health. I'm happy the doctors these days write well, but those days they didn't even write very well. So some of us who are social scientists could not understand your language. But that speaks to the materials that we give out, the adverts we put on TV, you know. Are they really user-friendly to my mother who just passed on 3 weeks back in Kakuto? Chotera? No, they are not. So we're saying the language barrier has been an issue. Then the poor timing, Then failure to follow regulations, because many people just produce materials for the sake. Some of these materials cannot really speak. Some are even, as we were saying, they were talking different messages from what is in policy and direction of the ministry. Then, of course, the resources issue, because information is expensive, but also we lack innovation in information sharing. I'll give an example of some of the young boys you saw around moving. They have reached 50,000 people with this GRM today through the digital media. 50,000 is what we have on the radar. We have 50,000. So could we have these innovative information sharing mechanisms? And that's, I think, the spirit of the digital strategy that the ministry recently launched. So how do we want to mitigate this? We want to have the Minister of Health to come up with uniform messaging on all critical MOH issues. We need to use innovative and the low-resource digital communications, because the communication budget has been so high in most of our offices as partners. But if you used, for example, like I said, the digital, we were 5,000 people here, the budget was so high, but we had 10 people who reached 50,000 people. So what does that mean in terms of costs? Then the other one, adherence to policy, including funding and implementing the MOH digital strategy. This, because we already have a strategy. It was launched by our Honorable Minister, I think here in Munyonyo. So how are we implementing it and facilitating it? Then also participatory information management. As I end, what we shall get out of this is appropriate messaging and information at all levels. As we're coming up, Mr. Chair, somebody came with another issue which we did handle about limited notification of deaths at community level, and I think that will be towards the next GRM. We shall discuss it further. But we can also discuss it later today. Thank you so much. You can clap for our members. Thank you so much.
Thank you very much, community engagement, and I think I gave you slightly 2 more minutes because that is the gist of the matter. There are a few issues with the digital media. I think I will handle this with the Commissioner Rooney later. These days, the young doctors, after removing a part of the body, they photograph it and put it on Twitter. I think while it is good for advertising on one side, it might be also, it needs regulation. Yeah. Ladies and gentlemen, you have heard from the 4 to address the issue. We handled the NCDs, we handled the communicable diseases, and we handled the HR and skills mix. The last one was the community engagement. Anybody moving with the microphone? There's one microphone here. We shall be totally orderly. First left row, middle row, and then we come to the right row. Can we start from here? We start from here. The left row, yes.
Thank you,
Kindly
Chair.
introduce yourself.
Thank you, Chair. Erikanand is my name, and I'm a medical doctor in Murago. To then see this team, one, I would like to know why this data collection tool going to take long. July 2024 is wrong. Can't we do something by the end of this year and we start getting this data? Because from the performance book here, there is no data for cervical cancer screening. It is painful, yet we screen women. Number 2, I've not heard about mental health, which is a very serious scourge. Maybe we could rethink about it. Thank you.
Yes, another person is one in front. We might also be democratic. We might take 2. Democracy, majority
thank you very
is not
much.
popular.
Once again, I'm Dr. Virungi D.H.O. Kanungu. Again, dealing with NCDs, I've not heard something about substance abuse and rehabilitation, especially alcohol abuse. Others say it is alcohol abusing us, but we need to have some of those rehabilitation centers at various levels. Then on road traffic accidents, one thing I have noticed, it appears as though most of these road engineering, does not take into consideration or do not engage public health engineers. They are looking at cutting costs, but how many people must die before some area is identified as a black spot, and when that is done, rather when it is identified, what measures are taken. Then on communicable diseases, well, I think the focus has also been larger on HIV, but I think we have a very big challenge with emerging antimicrobial resistance, and I think this needs to be addressed. The other day we had pigs being given ARVs. So now what happens when we get resistance in that area, and also unregulated distribution and use of herbicides, drugs, humans and animals, that's another area. So I just think I can say this for now. Thank you.
Can we go to the middle section, middle row? We are not going back to the left, middle row. If there's nobody in the middle row, yes?
Such as Bernard Chiria is my name, a member of parliament. I represent people of Diego County, Nakasongola district. Mine is going to the last second presenter about absenteeism. Where did the program of putting health workers on contract end? I would like you to enlighten me. Then I quoted the late Right Honorable Jacob Olanya, said that corruption starts with you. Everyone here is corrupt. That's what he said. And in all this, why we are here, the fact is we are all corrupt. And I request that as a country, how can we help our country? Because on our duties, I know that there is appraising the performance of these all civil servants. Where did it end? Because if these people are appraised, I think the regular performance of civil servants, in particular the health workers, can change. Are we continuing or it ended? I request that putting health workers on contract, it may change the absenteeism rate on our units. Thank you.
Thank you. Any person in the middle? The last person, the last. We have not gone to the right. The last person.
Thank you, Chair. My name is Patrick Edet from the National Cancer Awareness Organization. Now, on the issue of NCDs, I've not looked around, I've looked around, but the issues of nutrition is not clearly packaged. Because when you look at mitigating some of these non-communicable diseases, now, health is made at home. Yesterday they talked about it. I mean in communities, but only repaired in hospitals. But now, when you look at the issues of nutrition in this country, yes, we're talking about overnutrition, but also now, we need to see how nutrition is supposed to be taken care of to communities. Now, Parliament rolled out what we call the awareness campaign on food security. But the Ministry of Health, we have not seen clearly on how are we going to address the challenges around nutrition. If you come to Cancer Institute, even there is no unit for nutrition. I visited Nairobi Cancer Center. Even when patients are being clocked, who is there to show them what nutrition do they need at what level? So I think we need also to focus more on how do we bring up. The other day I looked at the newspaper here, Dr. Okuku clearly pointed out on how the role nutrition plays, food as medicine. But what you hear is all about medicine. A woman is feeding on 1 meal a day, but she's on highly toxic drugs, chemotherapy, or she's on chemo and radiation. Food and medicine goes together, but this is lacking in our healthcare. Thank you so much.
Thank you. Can we go to the right? We can start from the back end.
Thank you. Dr. Abdoni Virunji, DHO Rwanda. 2 issues, one on community engagement. We are all very aware that honestly there has been ongoing chronic inflammatory propaganda against these communities programs, especially from the area of the herbalists, the witch doctors, these who are manufacturing these new drinks, and we are very much aware that these could have a very negative effect on our health in terms of NCD development. Now, the ministry, in conjunction with other key stakeholders, have not come out to pronounce themselves about these issues. Much as we know that Uganda is a liberal economy, but we should make sure that there is no such inflammatory propaganda which actually affects the compliance of the community. When it comes to immunization, you go there as a DHO on the ground, you are trying to, educate and talk and tell people messages about how important immunization is. Somebody comes from the background and they start saying that's no sense, that's not possible, this is going to affect our children negatively. And we really think that if that hindrance is not tackled, then we are going to continue getting those blockades and we shall not succeed in engaging communities. Number 2 is about absenteeism. I can assure you, everyone who is listening in today has probably assumed that the healthcare system here is dead, because we have said that all health workers are what? They are not working. But here today we are here trying to celebrate, not celebrate, but trying to tell what has been done so far. So many cesarean sections have been done. So many, surgeries, so many attendances. I think we need to give due, we need to give, to appreciate where it is due. It's true that in every society where there is Jesus, there is also Judas. But let's try to appreciate those health workers who are on the ground working. It's true, there are those who are really committed. So when we say everyone is not working, we are demoralizing. I think the best thing to do is let's try to emphasize on our district leadership, identify those who are not doing their job, do the collective actions, but also motivate those who are working so that we can have the system running. Thank you very much.
Okay. Any other person? Yeah, Bonadiecho, yes. Bonadiecho, indeed, there are a few rotten apples in the community, amongst us, but most people work. And that's why community engagement said we should appreciate people who work. Yeah.
Thank you very much. I'm Dr. Ninkusima John Paul. I'm a member of Parliament for Uganda South. I also sit on the Health Committee of Parliament of Uganda. Under HR skills and mix, the presenter said that absenteeism is caused by drug stockouts. When we consider drug stockouts, it's a wide thing, it's a wide topic, that needs a lot of time to talk about and consider the causes, because he went ahead and said drug stockouts is caused by that it can be solved by timely delivery. But there are other issues that can cause drug stockouts, and I don't consider that as a serious cause of absenteeism. Because really, how do you leave the health facility and go home and sleep because there are no drugs? And again, when we consider drug stockouts, there are other causes, maybe inadequate reporting, things concerning drug quantification and so on, and maybe drug safety. Today morning, there is a session we had at Parliament there. There was a meeting. Someone was reporting that drug safety is no longer existing in Uganda. That is wrong, because you might not find drugs labeled drugs not for sale in our market, but there are countries, our neighbors, for example, Congo and the Southern Sudan, where they consider drugs that are labeled government of Uganda not for sale as the most original drugs. So how do they access those drugs? Because when they get them in Congo and Southern Sudan, you find they are highly marketable and expensive because they consider them more original. How do they get them? It means there are some loopholes how drugs leave our health centers and facilities and reach those other countries. So absenteeism and maybe issues concerning drug stockouts, we need a lot of time to talk about them, and maybe how to handle some cases. Because, for example, one time I was in NMS, Mr. Kamabare said that for them they deliver, for example, mama kits to all health center series. So when I was moving around my constituency, I asked some mothers whether they had ever picked mama kits from health center series, and they confirmed they had never picked them. I remember I reached the health center, one of my health centers, and there was no data concerning mama kits on that health center 3. But now, maybe my question would be, in such a case, how do we handle such people? Because we report to police, you report to DHOs, and maybe because the people are related to some extent, and things just end there. So we need to create a way of how we solve issues that affect drug stockouts. Thank you very much.
Thank you very much. Commissioner Stavia wanted to ask a question. I think I will give her that opportunity. Then I will give them time to answer. Can you take the microphone to her? Yeah. The minister's table is special. We apologize. That table is special. We shall give you opportunity to do it. Thank you.
Thank you, Chair.
Can you bring the microphone here now? Yes. Yes.
Thank you, Chair. One of my concerns was on prevention of NCDs, and the colleague behind there talked about nutrition. I think we need to have this as part of our health service delivery to prevent NCDs. But also, I didn't hear about physical activity centers, community physical activity centers, and also awareness about those. For the group which I was in, which was communicable diseases, we needed to further emphasize the issue of integration, regardless of what disease program you are in, to make sure that the other areas are addressed. Because people, today they come for immunization, but they have come with their malaria and they will go back with it. Yes, they have interfaced with the health system. So we need to think beyond the disease programs, look at the patients or the persons that we are serving to be able to achieve some of the glaring gaps that we looked at. And then there was an issue of bringing on board the private facilities as part of the work the DHOs will be doing to make sure that the people who start there also access services for both communicable and non-communicable diseases. Thank you.
Thank you. Can you bring it to the high table now? Yeah. Honorable Minister, you're
There's
on
one here. The MP for Uganda has alluded to the issue I wanted to raise about excuses of stockouts for being the reason why our health workers are always absent from health centers. First of all, the people who visit these health centers do not come, all of them, to pick drugs. Others may have come to make a test, or maybe to do a test, or maybe to consult. Not everyone will come for medication. And also, when health workers are not in a health facility, there are those people who may want just these simple drugs, which I know are always in these health centers, like Panadols, like headaches, some simple drug, and also the art clinic. So when you close completely, yet you have clients who come to your art clinics, how do you serve them when nobody, no health worker is at this center? So clearly, I don't think we get stockouts in the art clinics. No, we don't. And many things keep continuing in these health centers, aside of just issuing of prescriptions. Thank you.
Thank you. Members, can you kindly answer exactly what you were asked? Then I will wrap up. Thank you. We can start from the extreme.
Thank you so much. Most of the comments that were coming through the side of non-communicable diseases were actually supplements. However, one colleague asked about the timeline for the tool, which is July 2024, and I think there's a best person that can respond to that. The colleague was asking, why is it going to take that long for the tool to start working? So the technical team, I think, will address that. The other one was about mental health. So I think it is very important for us to incorporate mental health into our system, because you realize that mental illness is actually make the recovery and the healing process of our patients a bit very hard. So we need to incorporate this, and it's actually a very big burden, especially among the youth. Yes, so this needs to be incorporated in the system. Then the other one was about nutrition. It was also form of in a form of a supplement. So we really encourage the ministry to incorporate the nutrition strategies, bring the nutritionists on board, because we have them in our country. They are trained here. We bring them on board. And we also go ahead to educate the communities about the diets. If someone wants to prevent themselves against diabetes, what do they need to take and what do they have to avoid? And then also create other avenues of preventing other NCDs, like providing physical activity centers, so that our people can actually try to prevent rather than treating these NCDs. Yeah, I think the rest were really supplements. I thank you.
Thank you. There were comments on HR. One mentioned about contracts, and I think that speaks to the performance management cycle. If it is functionalized, I think that will be addressed under that. The issue of absenteeism versus stock outs, this was just one of the many contributing factors, not really a major one, but among others. And like you've said, those are the messages we pass on to health workers. When we're having stockouts, we tell them they should be available because some people come just for advice. But it is among the contributing, but not the major one. And as the DHO Rwanda noted, even absenteeism itself is not universal, but some affects in particular regions or areas. Maybe another comment to the MP who say that everyone here is corrupt. I think everyone has a potential to be corrupt, but not necessarily everyone is corrupt. Thank you.
Yes, next.
Thank you. I think mine were really comments, additions. I think someone mentioned something about antimicrobial resistance and was relating it to the other programs, but also for TB, we see multi-drug resistant TB. For HIV, we see HIV drug resistance, and these are really basically consequences of poor retention. So that I think was just to emphasize. Maybe the other thing I could just emphasize is that with the communicable diseases, we now see a lot of integration of NCDs in the control of communicable diseases. So we have interventions in many places to integrate cervical cancer screening, like Madam PS mentioned yesterday, but also there are also interventions to screen and manage other NCDs like diabetes and hypertension in these clinics that are managing clients for HIV, TB, and all that. So I think that's really to emphasize. Thank you.
Thank you, Chair. There were no particular questions, but I think comments, which we appreciate as community, and we continue to receive your input. But just to mention that as communities and people who are working with the communities, we want to have a genuine dialogue, Minister, with you. For example, if you're talking about herbalists, yes, are we going to abolish them? For us as communities, we take them as the health workers that we have been living with, and they have been assisting the communities. So the dialogue is, from a research background, what do they use to treat some of these diseases? We're already discussing, for example, in malaria about mosquito repellent plants, and they do amazing work. And for somebody who looks at them may think that probably that one, we need now the artificial ones. When you go to the artificial ones, they use the very plants, even the drugs, I'm very sure for you who are medical people. We use the same grasses, the same trees to have the panados and other issues. So I think we need to have a lot of research and dialogue between the community innovations and also what we have in science. The other issue is, of course, somebody stressed the issue of appreciating those who do work, because being part of the support supervision through HIPAC and other elements. But yes, you go and some of these hospitals, you find people have worked almost for 10 plus hours. They don't have enough staff and they are struggling. So how do we appreciate them? How do we motivate them? Motivation is another issue. You may have a big salary, but you're not motivated to. Actually, you even get stressed and depressed because you have a lot of money being paid to you. I worked with an NGO and had that. You wake up at 4 in the night and sleep at 10 in the evening, and yes, they give you a good salary, but are you motivated? When you even come to work, you know, you're traveling, I don't know how many hours. For those who have been on share, you can testify on this. You're doing a lot of work, but you really don't have the motivation and attitude. So how do we probably improve the HR element within the ministry? And we can borrow from some NGOs, some partners who have done that. Dr. Stavia, my friend, also talked about integration, which I also mentioned. Yes, Honorable Minister, this is the opportunity to talk to you that we are not only integrating the disease elements and, you know, the departments, but yesterday I was on Twitter Space for East Africa with the IANASO, and we're talking about climate change and malaria. There are so many issues that came up. You know, how do you work together with now climate change issues and then the health issues? So the integration even goes beyond the disease elements, but how do we probably look at the global goals, the sustainable development goals, and work with them to have innovations around them? Lastly, I think I need to thank you. Thank you so much. I don't have some other issues. Thank you.
Thank you very much. Maybe this one will go to the members of parliament. We always want to throw back. The road traffic accidents. One of the major causes is motor vehicle modification. Motor vehicle modification. You have seen people moving with the hunting lights. You have seen people moving with the spotlights at night. What are we going to do? Maybe these are the questions we should ask. The age of operating plants. Yesterday I saw somebody driving a link bus and he's on WhatsApp. Can you imagine? Should we raise the age of driving buses to 50? Yeah. For sure. You get a young boy of 25, is driving a Sino truck of 40 ton, he's busy on WhatsApp, and they're the ones causing accidents. So those are some of the issues we should throw back to the members of parliament. They are the ones in the kitchen. So you let us know about that. And then sector collaboration. Should we bring up sectors before we discuss other issues? Those are the few things I wanted to put forward. Please, when your time is over, can you kindly go back? Then we have the last three. We shall start, you can go? Yeah. We can start with the quality of care improvement. Then next will be health financing and maternal and child health, which occupies most of our work, will be the last. Thank you. Can we start with quality of care improvement?
Thank you so much, Chair. I'm by names of Didas Rutunje. I work as the Regional Quality Improvement Officer for Kigezi. I was in the team or in the group of quality of care, and we discussed a number of issues that are regarding the quality of care in the country. And among them, we listed several of them, and allow me go through them. We have the issue of leadership and governance, where we see there are weak regulations and supervisions, a lack of internal supervisions, both at facility level, at district level, and also failure to enforce standards at all levels. There is the issue of poor referral system in the regions, which is leading to poor outcomes, whereby most of the teams are not observing the referral system due to non-operationalization of the referral system. There is a lack of involvement of all staff, especially in implementation of all interventions, and here we called it verticalization of activities, where we say this is the focal person for certain activity, and everything is left to the focal person at that moment of time, and it summarizes it in the form of teamwork. Another issue regarding quality of care was money extortion and corruption among the staff or the health workers and local government, which leads to poor service delivery. And here we see some of the people have to pay for the free services. Another issue we also discussed was the limited knowledge of health workers in relation to the protocols, the SOPs, and also the performance indicators. Another issue was inadequate data use to identify problems in order to align specific interventions. Non-availability of the SOPs, and even those which are available are poorly utilized. There is poor attitude and mindset of health workers, and here we look at attendance to the patients and also commitment to duty. Another issue regarding quality of care, we saw diminished ethical etiquette among the health workers, where most times you go to a facility and you find health workers attending to a patient, at the same time they're on WhatsApp, they're on phones, and most times there's also no consideration for the special groups. Another issue was there is limited time that is offered to patients, and hence little information is good from patients, which leads to poor management at the end of the day. And here we looked at the neck syndrome, whereby you are having many patients and we are saying next, hence taking little history. Then long waiting time by patients, and this has greatly affected the client satisfaction levels among clients seeking care. Another issue was lack of basic tools to use while managing patients, and we looked at only basic tools like the weighing scale, the BP machines. Another issue was poor or no duty schedules, and this contributes to the poor outputs by staff. Another issue was lack of awareness of quality issues by health workers and the general public. We also discussed issues of poor hygiene and sanitation. We find that facilities there is no running water, the toilets are not available. If they are available, they are not washed, they are not clean, and our environment is in a mess. Another quality of care issue was poor documentation of the primary tools and reporting, and this is causing the poor quality, data quality issues. Then no feedback, no client feedbacks, and here we looked at listening to the patient's voice, whereby we are not getting feedback from the patients. Next was assessment of the implementation of standards is not timely, and here we are looking at like the health facility quality of care assessment, known as the HFQAP. Then another quality of care issue was fear by patients to demand the services that they deserve. It was raised that patients, some of them fear to ask the health workers the services that they deserve. Poor interpersonal skills among the health workers and the district local government teams is also another issue that is causing a poor quality of care. Privacy of patients, where we see some of the clinical rooms or the working areas are not well established to offer privacy of the patient. It was also discussed the poor, or called the power interruptions that leads to untimely results, and this was specific to the labs, laboratories, and also patient congestion. And we saw that once the facilities are congested, at the end of the day, they are likely to go home with poor services. So we discussed some of the countermeasures, and the discussion was still going on. For the issue of money extortion, corruption among health workers and other local government staff, we discussed as a way forward to enforce standards, reprimand culprits, have proactiveness of the management, and also conduct community sensitizations and feedback. For the issue of limited knowledge of health workers in relation to protocols, SOPs, and performance indicators, there is a need to build capacity to enhance skills of staff in order to provide quality of care services. For the case of inadequate data use, we shall enforce the performance reviews at facility level, district level, at regional level, in order to utilize available data and align strategies according to the performance gaps. Then, for the issue of patients fearing to demand for services, there is a need to operationalize the client charter so as the clients are able to know their rights. No feedback. Here we shall be conducting client satisfaction surveys to ascertain the level of satisfaction and respond to the identified unmet needs, or call them expectations of the patients. And also, we looked at, in order to improve the quality of care, we need to functionalize the existing structures at regional them, the MPDSR committees, the district QI committees, the regional QI committees, as some of the platforms to discuss these issues that are affecting the quality of care. This is all that we discussed in this group, and the two members will complement. Thank you so much.
Thank you. Let's be in time. The next, health financing. They might charge us for warming food. So let's be in time. By the next 30 minutes, we should be finishing.
Yes, I hope this is okay. Protocol observed. Good afternoon, everyone. My name is Cuthbert Msime, and I work with the Think Well team in Uganda. And I'm privileged to be standing here to represent the health financing group, that is group number 6. So, Chair, I recognize that I'm standing in people's lunchtime, having seen that the meal cards have been shared. So I'll try to run as fast as I can through what we managed to discuss as a group. As health financing, we had several aspects talked about, but we had time to speak through 4 major issues. One is the low insurance uptake, the external financing, which remains to be a major source of financing for the health sector, the low per capita spending against the standard, which is $86, and then the low budget absorption for external funds. So I'll quickly move through the low insurance coverage, and I know this is a topic of interest for almost all of us. So in terms of possible causes that we were able to identify as to why we have low insurance coverage, which is about 2.1%, we had about 5 major points, and one of them is the lack of a legal framework. Of course, I will talk about that in a second. The other one is the community sort of sensitization. So we are saying the community has not appreciated the value of insurance, so the attitude is still very low, and we need to work on this. The current premiums that are existing, and majorly these are through the private sector, they are deemed to be expensive for most of the households, and especially the rural communities, but also the urban poor. The other one is management of private insurance, which has made people lose interest, because we've had complaints severally that service providers, so the private health facilities give out services, and then insurance companies take ages to pay them, so some of them are a bit frustrated. I think that is something that also needs to be addressed. But also the restrictive approach of the package, whereby you have an insurance card, but then when you move into this facility, they tell you, no, we don't offer this service under insurance, and then you end up again paying out of pocket. So in terms of proposed interventions, one is fast-tracking the legal framework of the NHS bill, and I'm glad the Honorable Minister gave us an update yesterday of the steps that have been taken, but also I know we need to give her the support that she needs and her team. Secondly is awareness about insurance package and intensive community sensitization. We need to let the communities know of what is coming and build this momentum, even as the bill is going through the several discussions. Addressing the fund management risks, we need to be aware of what is entailed in this NHIS bill. In other words, is the administrative cost going to be overly high that is going to maybe drain the sole purpose of the scheme? But also we need an implementation framework to be in place as we anticipate the bill to come, and this should be communicated to all the stakeholders so that they are aware of what their roles are within the National Health Insurance Scheme. So in terms of responsibility, of course, this is all of us, but majorly the Ministry of Health as the steering sort of driver for this, the community, and also I'm glad we have parliamentary representation. So I think this is a concerted effort, so we all need to be in place for this. And the second was on external financing, which remains to be a major source of financing. We had about 4 possible causes for this. One is the low funding of the public sector. We know that there is a shortage of resources available for financing the health sector. So government is unable to fully finance, all the promised sort of packages for the health, but we all know that there are also competing priorities. We recognize that there's a small size of the economy relative to the population that has to be served, but also there's still some relative weak partnership between government and the private sector. So we proposed about 3 interventions to try and mitigate this. One is constant engagement. We recognize that the Minister of Finance needs to pay attention to the needs of Minister of Health, of the health sector as a productive sector, through improved partnership and prioritization of investment. Then the other is working with the private sector. We know that there was a lot that was gained during the COVID, and you remember how the private sector came in handy. So we are saying we need to have the government work with the private sector to come and mitigate, or to come and put in more efforts. And this should be able to help us to sustain, because we know that donor funding is not sustainable. But if we work with the private sector, which is already established here, it should be able to give us mileage. The other one was low per capita spending in relation to the global standard of $86. So we are saying the allocations are low vis-a-vis the population, and we recognize that there's a challenge of competing government priorities, because as you all know, and as we've been seeing from the various presentations that have been made, we see that there are several priorities that the government is trying to put money into, and the health sector is not in isolation of those. So we think that we need to be very innovative as the health sector, and one of the ways is through pooled financing as one of the strategic purchasing sort of mechanisms to help us generate more money into the sector. But as earlier highlighted, for example, now that we are anticipating the National Health Insurance Bill, we are saying 2 things must happen. One is we need to make sure that we keep the cost of the administrative cost of this scheme very low, because the moment it goes high, then we are losing the sole purpose. But also the fact that we must make sure that everyone contributes to this as a sustainable sort of mechanism to have money to run this scheme. But also have to continuously advocate for more resources from the government, but also from the private sector, as well as the health development partners. And this is a responsibility of the Minister of Finance and the Minister of Health, of course, with our support as the civil society and everyone else.
Can you wind up?
Yeah, this is my last point. The low budget and absorption for external funds. There are about 3 factors that we identified. We are saying the design of these projects needs to be looked into as one of the possible causes as to why we are having low absorption in terms of procurement, but also the management of these projects. We have issues of efficiency and conditionalities whereby you find that the health development partner or the donor requires you to have several approval stages, and by the time you go through all those stages, probably the time has elapsed and the money is recalled. We also talked about the aspect of questionable capacity for some of the local contractors and suppliers, whereby you trust someone, take them through the process, but at the end of the day, they fail to deliver, and the results are not very good. So that is something that needs to be looked into. Disbursement delays and PFM Act challenges. We are saying that the health program needs to be looked at with its uniqueness in relation to other sectors. Some of the aspects that we are looking at, or that we have in the PFM, do not actually favor the health sub-program, as earlier highlighted on the issue of EMHS. Delayed accountability of funds by the recipients. Sometimes we also, as recipients of these funds, we are not accounting in time and not giving proper accountability, both financial and social. So we are saying in terms of proposed interventions that there should be some level of trust by the health development partners, because we know that the government has established certain systems, and if the health development partners can trust these systems and let some of the processes move faster, then we should be able to absorb the budget within time. But also early and open declaration of available resources by the partners. If you have the money that you intend to put in a certain sector, it should be declared so that when the planning is happening, then that money is integrated, and this can help us to sort of avoid supplementary budgets. And in the issue of questionable capacity, we need due diligence during procurement, but also we need to prioritize accountability of the funds received for us to try and mitigate low budget absorption. I thank you.
Thank you. The last one, maternal and child health.
I will be very brief, don't mind. I know you are worried. But it's like we do not fear thromboembolic disorders. Can we all rise up? Can we all stand? Can we all stand? And at least stretch. Can you move your leg? Can afford? Please project my thing. Thank you. You can see. You can take up your seats. It's very, very bad to be admitted from here. So I'm representing reproductive and child health, and I'm going to be very brief. Okay. We have had enough causes. So I'll go to the recommendations. Your thing is not moving. Your thing is not moving? Okay. So the first issue was about increased total fertility rate, and there are so many contributing factors: high unmet need for family planning, low uptake, inadequate family planning commodities. The recommendation that government and partners should prioritize improved budget for family planning commodities, and we should also strengthen programming. And that one should be taken seriously. Minimal reduction in the prevalence of teenage pregnancy. So many causes. I don't want to read all of them, but of course we have limitation in handling teenagers, services and providers, very low level information given to adolescents. Where do they go? Who receives them? Who cares for them? What about in the community? Leave along the health facilities. The recommendations are strengthen school health visits, actually say strengthen school health programs. And there are very many things under school health. Promote adolescent health clinics in all health care settings. Build the capacity of health workers on adolescent service provision. For adolescents who are out of school, empower parents to talk about sexuality with their children, design interventions that keep the girl child and adolescent in schools. Empower teachers at schools, and family planning should be considered. So many, I won't read all of them, but since the presentation we shall read. We had the part number 4, 5, and 6. 4 was about institutional maternal mortality, increase the institutional maternal mortality, and Dr. Diambo reminded us that we should also include neonatal newborn mortality. And we said yes. Then number 5 was about decline in IPT3 coverage, ANC4 and deliveries in health facilities. And then number 6 was about screening for anemia in pregnancy. And most of us attended the Safe Motherhood Conference. And we addressed these issues comprehensively. We know the causes and we know what to do. So we made a recommendation that we should strengthen implementation of the resolutions of the Safe Motherhood Conference that was held just a week ago. And Dr. Mugahi, the Commissioner, Director Clinical Services, Dr. Bagara, I saw him here, and all other well-wishers and senior management will embrace this. Number 7 was about 52% of health center 4s provide CMOC services, and then 37 health center 4 do not provide cesarean section services. And our recommendation that all health center 4s should be functionalized. Where we have a gap of equipment should be prioritized, and implementing partners should be interested. Actually, last night I am very sorry. I harassed one of the IPs in my region, in the 2 regions, Because I asked, who is the IP for Bunyoro? Then they told me, they are your friends. Which friends? They said, Beira. They said, who is in Mubende? They said, Beira is coming, Maradma has gone. I said, now, how dare would you have all your facilities as in the last 10 on the league table? And I told them, you wake up. If it is what has brought you to Mubende, me, I will trace you from my district. But I will not trace you. Please come work together. We'll make sure that we improve all indicators. It is very bad to talk about comprehensive HIV care and you cannot address a newborn. You cannot address a pregnant mother. It must be broad-based. And then the issue of blood transfusion, we say 100, by the time we come for the next GRIM, we should have a report about 100% blood transfusion functionality for all CEMOC facilities. I actually don't understand, because the new structure says putting doctors, 2 doctors at their center 3. But remember, even in the absence of doctors, mothers deliver. So it means we should be actually transfusing even at health center 3. But even the health center 4 and hospital we have cannot transfuse 100%? That's not true. Madam Minister and PS, blood availability should not be a concern. When I hear about shortage of blood, me, I cry, I laugh, but I cry inside. During COVID, at the intense of COVID-1, when we were in lockdown, that time I was in blood bank, I collected and supplied blood the entire country in the first 6 months. Did the blood donors die? But the question should be answered by ourselves who are under this roof. That in the last 2 years, how many of us under this roof now have donated at least a single unit of blood? Then number 8 was about slow reduction in nutritional indicators for the under 5s, and we recommended that there should be functionalization of the nutritional committees at all levels. But also, we need to implement the National Nutrition Action Plan. And it is available. The problem, Chair and the senior managers, some of these things, even people don't know them. And that's where the problem begins. So we need to disseminate what we write. We must disseminate it on all forums, including what? Including websites. Thank you very much. That is work for maternity and child health.
Thank you very much, and you can take your seat. We shall have extremely few questions. I know people are tired, and we will need to finish in time. Start from here, the 2 people. Yes.
Thank you so much. I'm Jackie Katana from Faith for Family Health Initiative. My question is to the person who presented on health financing and proposed a number of innovations. I always tell people, however much I'm an advocate for health financing, when you look at our domestic resources and the sources, it's like you're squeezing a rock. So I make a lot of noise about the 15% Abuja, but the reality is, when will we get there? So we would rather now start thinking, and that's what I talked about in the remarks yesterday, is about efficiency. And I called it allocative efficiency that goes actually from allocation to expenditure and to absorption. There's a study we involved in, and I think also UNAIDS did one on efficiency, but I'll talk about the one of family planning. We discovered that whereas people in the community, for example, needed pills, most of the resources were put into the procurement of injectables. So people would come for pills and they don't get them, and the injectables are getting expired. That's wastage. So how can we align our allocation to the needs? I've never worked in local government. A few things I now pick them in the literature. But Honorable Minister, how easy is it, for example, when they already allocate resources to a particular budget line, and you realize the needs have shifted, how can you move them from one need to another? And also, if, for example, it is allocated to family planning, but you realize that the need is in malaria now, and malaria is affecting a number of indicators, how easy is it to have that easy kind of reallocation? The one I know is in NGO and others. So otherwise, we are putting resources where they are not adding value, yet the needs in some areas continue to grow. Thank you.
Thank you. There's a gentleman who has been putting up his hand. Excuse me? Gentleman there, and then he will come to you.
Well, thank you very much. Dr. Roy is my name. Just two quick observations. We've been talking a lot about absenteeism, but there's also something called presenteeism, which we haven't talked about. I think that is also another big problem. People will clock in, and it will take 3 hours before you see anything. I think we should also be looking at that, because that may also be part of the problem. Sorting out absenteeism without strategizing for that other problem is going to be a challenge. And obviously, I think also our appraisal systems are a bit weak. They are reactive, not proactive. We need to have good job plans, not only job descriptions, but proactive job plans that actively monitor how we perform. And then finally, a strategy on patient-centered supervision. If a patient does not receive a service within a certain set time, part of a patient's charter, I would think, that patient has a right to report. And I think that would give some kind of improved supervision. Most of us supervisors are usually complicit, and you are most likely going to defend your health worker. Getting it from the person who seeks the services may be more efficient. Thank you.
The last on this side.
Thank you, Chair. Once again, I'm Dr. Birunji Mutahunga, DHO Kanungu, and I want to respond to low coverage for health insurance. There have been, conflicting messages, especially from the politicians. And I think to this end, I want first of all thank our Honorable Minister, Honorable Ruth Acheng, for she has been consistent at every opportunity talking about health insurance. Whereas I have not heard this, and we have been talking about community engagement. I think members of parliament who are here and are members of the health committee, this is something that needs to be emphasized because it is part of community engagement to prepare the population about the upcoming health insurance. Then even before this comes into play, I have not seen guidelines to do with the Uganda ambulance system. No, there are these ambulances that have been deployed, as we have mentioned, but sometimes you find the vehicle is there, but the fuel is not there. Do we have a standard guideline, for example, that people would base on for the co-payment? Because these have been issues coming up when someone is asked to co-pay and maybe put fuel, then there is noise around that, this is supposed to be free. So I just think, even before the framework they were talking about comes into play, there are certain things that could be done. So I think it would be good to have some guidelines, say for co-payments in some of those peculiar situations. I thank you.
Middle row, yes.
Members. Hello. Ladies and gentlemen, during this joint review mission, I would love us that we go with a recommendation, and I would begin with recruitment, which will also spill over to the performance. One is about districts with wage and those with non-wage, and I would love that we listen carefully. Now, from this meeting, I would love that we put a recommendation
because I know the stakeholders who sat and wrote that let there be a ban, we could also write our recommendation, and then we see how we can lift the ban in a stepwise manner, maybe beginning with health sector. That is my appeal, that today's recommendation, we recommend lifting of a ban in a stepwise manner, and that is for districts with wage. And then for districts with non-wage, I would love that we have, we be permitted to have in our local government, we have environment and trade-off. And also I request that our PS see how we can functionalize our medical board in regional referrals. Isachra was sent to regional referrals, however, they lacked a tool to implement. And I would love that if, for example, our medical boards function in regional referrals, those who are to retire on medical grounds would give a way to recruit other health workers. Thank you.
Yeah, thank you. Dr. Kware, you wanted to say something?
No, just conclude.
Okay. We wind up. Can we get, is there any burning question on the right? No. The three members, is there anything which was raised for you? We can start with the maternal and child health, and then we shall go this side. Did you have anything?
No, I did not have anything about maternal and reproductive health, but you know, the senior Dr. Wawi mentioned about absenteeism versus presenteeism. Let me share with you just 2 minutes about what I do in my management.
2 minutes is a lot. Yes, 70
seconds. No, Dr. Salvi, don't shake your head, because you know these are governance and leadership issues. So the issue of health workers or even managers looking at job description for use for appraisal, I find it very irrelevant. Yet we have so many things we have been talking about here. So I think the problems that we have in our sector, in our districts, in our departments can translate into key outputs. And then we can set clear indicators, and then we set the targets, and we monitor them every quarter. In my district, I did not pay doctors. Why? When I count, if I have a bare minimum, 12 ward rounds a month, a quarter, and we have only attempted 2 rounds, why should I pay you? I don't pay you. It's not because you're a doctor. So I think we need to be very serious, because we shall keep massaging something. And I have realized that as managers, we need to be in it ourselves, and then we move forward. And that's why I request the Ministry of Health that, as the DG suggested, to have standardized performance plans and contracts for managers and all of us. Let's also start from there. We need to know which level, at every level, so that we are all accountable and we speak the same thing at the end of the day. That is the only solution I can see. Thank you.
Thank you very much. And this other team?
Thank you so much. I think to me, emphasize what was raised by the audience, patient-centeredness, and also having standard guidelines for the ambulance use, which I think should also be taken up, and also the functionalization of bodies.
Okay, that's enough. I think people are tired. Yes, very true. Otherwise, ladies and gentlemen, thank you very much. Let me stop here, but I will say one single word, that kindly, health workers, let's pay attention to the bill, and let's prepare the souls and hearts of the community for the bill, so that when it is enacted, we all become participants. Thank you very much. I can hand over to Dr. Kware. Thank you.
Thank you very much. I think this was a very exciting engagement. Join me to appreciate the groups and the chair. I know we are running out of time. I think the request he will come. So I think we request the group rapporteurs to submit those notes to the Secretariat, because there's a lot of material that you have shared, and I noticed that some of it was from your script. The Secretariat will synthesize and will definitely come out with good, actionable interventions. Let's thank everybody once again as we get on to lunch. Our lunch is ready long time ago. I hope it is still warm. Let's go to the same venue. You have got the meal cards already. And Honorable Minister, I suggest that we reconvene at 4:30? 4:30. We reconvene at 4:30 for closure, launch and closure. It's going to be short, I promise you. No long speeches. We shall have exit statements, which are normally shorter than the initial statements at the beginning. So it will be short, and by probably 5:15, we should be out of here. So let's go down to the poolside where we ate lunch yesterday, grab something, and we'll come back here, 4:30. Thank you very much. Thank you very much. Good. Honorable Minister.
Allow me to congratulate the Department of Planning upon this work. We are glad that we are having our first atlas, and we know that a lot of work has gone into it, as explained. Let's take note that it is the first edition of the atlas. Therefore, there are bound to be mistakes and many other challenges. I am glad that they have made it a living document for amendments every now and then. So take time and read. We will appreciate your input into the document so that when we make amendments, then we can correct whatever has not been well done. So that is for all of you. I hope you will all be able to get a copy. But if you traveled by bus, this book is a little bit heavy. They might charge you for extra luggage. And more so if you took a flight here, it will cost you even more. But let's appreciate the planning department for this job. Thank you very much.
Thank you very much, Honorable Minister, for launching the first National Health Facility Atlas. Okay, so the next agenda will be to award the best performers in those different categories. And the Commissioner Planning is going to present those best performers to receive their awards. So over to Dr. Sarah. Honorable Minister, we again invite you and the Minister of State, Permanent Secretary, Dr. Laro, standing in for DG, and all the senior people who were here. If you don't mind, you can come back. Yes. Okay. Permanent Secretary, please join. We are going to do this quickly, so when they read your name, you need to come over pretty fast so that we don't take a lot of time.
Some can go the other side. The other side. Thank you, Honorable Minister of Health, Honorable Minister of State for Primary Health Care, PS, and all protocol observed. It is quite some time since we last gave accolades to the best performing local governments or health facilities for various reasons, but I would like to say also now that these awards are given based on availability of resources, as the word goes these days. So we were privileged this time to get resources from the Embassy of Ireland, and we really appreciate that today we can honor some of the best performing institutions in terms of the results that we discussed yesterday. So for the local governments, as you heard yesterday, we would like to invite Chiruhura District Local Government for taking the first position in the local government health service delivery league table. You are welcome, DHO and the other district leadership. You can come forward. I'm sure you have really worked hard for this, and you deserve a very big clap. Thank you. And next, Manafwa District Local Government, prepare to come over to receive your accolade. Manafwa District. As Manafwa comes, Soroti City, prepare to come. Oh, sorry, Manafwa, wait, sorry, Honorable, I'm very sorry. My sincere apologies, Honorable Minister. Second position is none other than Lira City. Lira City. Lira City, can we have you come over to receive your accolade? Lira City. So the Honorable Minister will receive the accolade on behalf of Lira City. Thank you. I think they wanted her to receive it on their behalf. So next, Manafwa District Local Government will be followed by Soroti. Soroti, prepare to come. Manafwa, please hurry up. Soroti, if you are in the room, get up. So Manafwa, position number 3 in the district league table. Are you going to get for Soroti? Where's Soroti? Soroti City. Okay. Rubanda District, prepare to come. Soroti, then Rubanda District Local Government. So, okay, Soroti they'll receive it later. Rubanda District, 5th position. So next we are going to the regional referral hospitals. Mbale Regional Referral Hospitals was ranked number 1. Mbale Regional Referral Hospital was followed. Board member will receive on behalf of Mbale. Followed by Hoima Regional Referral Hospital. St. Mary's Lacho, prepare to come as number 3. Hoima. That is for Soroti district. So Honorable Mohanga is receiving on behalf of Soroti City. So do we have a representative for Hoima? Second position, and St. Mary's Lacho. I saw Dr. Rach here from UCMB. Please, Dr. Rach, please receive third position among the regional referral hospitals and large PNFPs. St. Mary's Lacho. For the general hospitals, Chitugum and Mukono prepare to come up. General hospitals, we have Chitugum taking first position among the general hospitals. Followed by Mukono. So Chitugum first. Number one, let us clap for Chitugum. We know that Uganda had always been number one using the standard unit of output. This time round we used other variables, the diagnostic related groups, and Chitugum emerged number one. Mukono General Hospital, you are ranking number 2. Thank you. We always see the very many patients there as we pass by Mukono. A big hand clap. This is a new hospital and they've really performed very well. Congratulations, everybody's happy for you, Mukono. Health Center Falls, we prepare Mukuju from Tororo District. Mukuju Health Center 4 from Tororo District. Who is taking? Sure. Followed by Bujubudi. Bujubudi is also one of the new health center 4s in Chegegwa District. Chegegwa, somebody from Chegegwa to receive on behalf of Bujubudi. Bujubudi, Chegegwa District. There's somebody. We have Bujubudi Health Center 4 is one of the refugee hosting areas or settlements, and they are really performing very well. So those are the accolades. Let's give a final round of applause for all those who have been able to achieve. Thank you.
Thank you very much, Honorable Minister. Please, others who have not got, work hard. Next year, the awards will be bigger than this. Okay, so now we go to the final event, and I want to hand over to Director Laro to moderate the activity of the exit statements and the final closure by the Honorable Minister.
Good evening. Good evening. We are coming to the closure, and first let's applaud all the other chairpersons and those who have got awards. I've been asked to do this in 15 minutes, and I'm actually going to do that. So I want to invite all the people who are going to make closing remarks to come in front. The Honorable Minister. Okay. I think without any more, let me invite the first person to make the closing statement. I want to invite the private sector representative. Can we have a good mic? Look like this is suffering from the late afternoon syndrome. I think probably use the upper one, it is better. After him, we'll have the civil society organization representative. After.
Thank you, Dr. Valaro. Ladies and gentlemen, Honourable Minister, Ministers of State, all protocol observed. I have 5 pages, but I promise they're very small and the writing is very large, so I won't be too long. On behalf of the private sector, I really would like to thank the organisers, the Minister, all involved for your very kind invitation, and can promise you that the private sector, all of the private sector, and I'm here as the Vice Chairman of the Uganda Healthcare Federation, which is the body which represents all of the players in the private healthcare field in Uganda, that the private sector is fully behind the development and hopeful implementation of the bill, National Insurance Bill, and we look forward to an increasingly vibrant and hopefully increasingly well-funded public healthcare sector. On behalf of the private sector, I would also like to acknowledge and appreciate the significant improvements that we have seen highlighted in key health performance areas over the past 2 days. Obviously, clearly there is some considerable way to go, but things are broadly and markedly moving in the right direction. That's been demonstrated quite clearly over the past 2 days. Obviously, several key challenges remain, one of which has been discussed fairly in depth, that is that of absenteeism and, as our colleague mentioned, also presenteeism in healthcare facilities. Part of the answer, thinking back to my previous work in the pharmaceutical industry, in over 35 years in about 5 continents, is to appreciate those who perform, those who go the extra mile, such as the colleagues we've just applauded and recognised now for their achievements and hard work. That's why I think personally that performance-based employment, performance-based contracts are the way forward, quite frankly. In addition, full motivational performance appraisals across the healthcare sector, ideally twice a year, but maybe once a year to start off with. We saw today one of the colleagues in his presentation saying that the majority of colleagues in his area, the majority had been appraised. I think in the private healthcare sector, all are appraised, and ideally all should be appraised annually, and in an ideal world, and of course we don't live in an ideal world, twice yearly. Necessarily moving on from this, we would move to performance-based salary increments. Salary increments that are recognising the hard work, the motivation, the desire to go the extra mile that colleagues demonstrate will be recognised in their performance appraisal, and eventually, hopefully sooner rather than later, that will be, as I say, that will be recognised not in across-the-board salary increments, but salary increments based on individual performance. The higher the performance, the greater the commitment, the better the performance, the better the salary increment. This necessarily means that maybe some colleagues will have a lower salary increment, or indeed, in some cases, none. When we implemented this in my previous company, there was a feeling that this would demotivate those who received a lower or no salary increment. But we have to look at it from the other side of the coin, in my opinion. The demotivation that is felt by the high achievers, those who are committed 100%, when they receive the same salary increment as those of their colleagues who maybe have not as performed as well. So, moving on briefly, we saw the various progresses in the key performance areas. One thing that struck me, though, was that not all are assessed. In one of the presentations yesterday, 49% of the parameters were not assessed, which is getting on for, or half. Now, normally we would look at what we call smart performance assessments, and here I'm not talking about individual, but the therapeutic and healthcare performance assessments. SMART, specific, measurable, achievable, relevant, and time-bound. Measurable, in other words, accessible. And if a healthcare parameter is not measurable or accessible, it may be worth considering, should it be a parameter for assessment. But if it can be measured and if it can be assessed, then it must be. And briefly, finally, and this is something that the Honourable Minister mentioned briefly yesterday, I'm easily confused, that goes without saying, but I was a little confused yesterday when I saw the presentation from our colleague from, or heard the presentation from our colleague from the Ministry of Finance and Development, where some of the figures that he was presenting differed in some respects from those that the DG, the Director General, had presented earlier on in the day. Now, for those who are easily confused like myself, that is confusing. But more importantly, I think it is critical that we start from the same statistical base. And here I am assuming and believe that those figures that are presented or were presented by the Director General are the correct ones. Finally, and thank you once again for your time, I would appreciate, and I was very pleased to hear the mentioning of mental health. You know, mental health care, mental health funding, in some ways is the orphan child of healthcare, not just in Africa, but indeed in Europe and elsewhere in the developed world. And I think it is an area that requires deeper focus and deeper financing and indeed deeper development. And it is, from my personal perspective, and I think as an individual, it is heartening to see that it is not forgotten here in the deliberations we've had over the past couple of days. Once again, on behalf of the private sector, I'd like to thank you for the invitation and thank you for the progress you've made on behalf of patients in Uganda and everybody in the country. Thank you.
Thank you. Let's applaud the CEO of CIPLA for so we are going to listen from the civil society team, and we want really to thank the private sector for summarizing his speech with the 6-page speech in less than 5 minutes. Thank you very much.
Thank you so much. On behalf of civil society, I'm called Mulumba Matthias Suna. I represent civil society on HIPAC. I come from the malaria constituency and I lead the Coalition for Malaria civil society organizations called UCAM. As civil society, we thought we could just summarize what we have got today in a few slides, and I think we should take as technology comes on board, just to say that we had a few highlights that we observed during the process of the GRM, and also took home, and we also have a few asks that we think government can support, especially within the next year health program. We, of course, at the beginning want to thank everybody, especially the Minister of Health, for organizing this GRM. We don't take it for granted as civil society to be invited to this process. Continuously, civil society is getting on board, and we are happy that all the time there's a mention of civil society, and probably the theme that we all observed about community engagement, and that's where we really work, and we think we are part of that community engagement. We appreciate the partners who have made us stay here for all these days, and also the support they have given through the process. We also appreciate the civil society who are here, but also other people who have served and helped us to go through this very effectively. There are many highlights and takeaways, but because I know I'm standing between almost darkness and time, I don't want to really go deep to mention each of these. But you can see we have a whole list of things that we have really picked from the GRM as civil society, which we may take home to implement as civil society, but those we can't implement, we are going to work with you all stakeholders to make sure that we follow them up, as our role as civil society is, of course, to do advocacy to make sure that things happen. So we shall take up that role where we can't implement some of these issues. I don't really want to go and read each of these, otherwise I'll be wasting a lot of time, and yet we don't have a lot of time. We have several asks that we have also thought about, and I'm very sure since the document that is going to be prepared at the end of this GRM is not ready, we're going to share many of these asks, and we hope you people are going to see them, and you're going to maybe respond to them, and then ensure that we also achieve what we want at the end of the year. Of course, some of these have been mentioned through the discussions. I just came from the podium a few minutes back where we talked about the community services, the community health department, and all that. They have been captured and have been part of the dialogue. And I don't want really, like I say, to go deep to really discuss many of these things that we have already talked about. Apart from the asks, of course, at the end of it all, we think we can integrate, like we said, as civil society, being part of the ministry, being part of the health department or health ministry. Our role is like the ministry itself at community level. We supplement the ministry, but we also have different angles of what we do. We are not only in health, we are in climate change, we are in nutrition, and we bring these rich innovations into health, and we think we can achieve using what we already have, wherever we go. This ladder explains where we come from as civil society in many engagements that we do. Of course, in many of these institutions, like the departments and Ministry of Health, you'll find some of them barely engage civil society at all times. But our hope is that at one point we are going to have community ownership. We are going to struggle to make sure that the communities themselves own the health programming, and therefore, like I said previously, we even reduce on the spending on the budget that we have for health, and ensure that communities themselves own. It's no longer a medical issue, but a community issue, like we said. As I end, and in conclusion, yes, we have so many ways we can reach and skin this goat. Our role as civil society is to bring everybody on board, especially the people who are being served. We may have people who have the resources, like we said, within the community insurance, but there are also those people who don't have the resources. So our role is to bring them together. Some of them are still not sure of what's going to happen. Some of them have not even seen the strategy, they have not contributed to it, but we think we can all participate through the voice of the communities as civil society. I just want to end here by thanking everybody and also not spending any more minutes. And we hope we shall be continuing to really work with you as the ministry, as partners, to support health development in the country. Thank you so much.
Thank you, Matthias. I think the civil society organization took the bar higher, so we want to applaud them for that. We are going to our next, okay, let's clap. Our next statement will come from the representative of the Health Development Partners. Let's welcome her.
Good afternoon to all. Just to start with the introduction, my name is Margarita Tileva. I'm the Deputy Representative of UNICEF, and I'm here on behalf of Munir Safieldin, the representative of UNICEF and chair of the Development Partner Group. Honorable Minister of Health, members of Parliament, the Permanent Secretary of Ministry of Health, representatives from the Ministry of Finance, Education, National Planning Authority, all the representatives from local government, civil society, and the private sector, ladies and gentlemen. It is a tremendous pleasure to be together with you today for this 29th Joint Health Sector Review meeting. Allow me first to start with congratulating the Ministry of Health under the resolute leadership of the Honorable Minister of Health, Dr. Acheng, for indeed the significant results achieved in advancing the health sector outcomes for the population of Uganda, despite of the significant and the far-reaching impacts of various crises, such as the COVID, the Ebola outbreak, and other public health emergencies that have impacted Uganda's healthcare system. The results shown in the annual health sector performance report, as well as the recently completed figures that came out from the Uganda Demographic Health Survey, are indeed encouraging. You have heard in the many presentations about the reduction of the maternal mortality rate, the under 5 mortality rate also reduced, as well as the infant mortality rate. The wasting among children under 5 is also reducing. The stunting in children under 5, although still short of the target that we aspire to. The prevalence of the obesity for both women, men, and children under 5 also reduced. And it is indeed a modest, encouraging to see that a modest increase in the percentage of women 15 to 49 years who are currently using any modern way on contraception. There is also an encouraging increase in the sanitation coverage, where 44% of the household are using improved toilet facility. All these results were achieved thanks to the dedicated and indeed tireless efforts of health professionals in the entire country, from the village health teams through the health centers, the general, regional, and national referral hospitals, and then all the way to all the colleagues and leaders working in the Ministry of Health, National Institute of Health, the health laboratories, and then medical stores, as well as the support from the private service providers. Under the wise guidance and the commendable leadership of the Ministry of Health professionals and the Honorable Minister of Health, all health system workers really tirelessly worked to ensure good health and well-being of Ugandan population, and they should be highly recognized and praised. Allow me to join also my heartfelt congratulations to all the districts and cities that have exhibited exceptional performance in the league table. It is increasingly evident that the effective leadership and good governance serve as fundamental pillars for enabling such noteworthy achievements. As development partners, we are very grateful from the opportunity to accompany the government of Uganda in its journey towards a transformed Ugandan society, seeking an increased household income and improved quality of life through sustainable and inclusive growth, employment, and wealth creation, as it is eloquently reflected in the vision and goals of the National Development Plan 3. As development partners, we do remain committed to continue to provide support to the government of Uganda in achieving the health sector targets through a shared vision focusing on strengthening the national health system and fostering resilience towards a healthier future for all Ugandans. We will continue to collectively work with the government in addressing the pressing challenges such as the diminishing immunization rates, the lower than desired still utilization of family planning services, the still quite high teenage pregnancy rate and increasing adolescent birth rate, and the persisting challenges of stunting. Also, nationally, 14% of the households have hand washing facilities with water and soap, and this is also an area that we need to put our efforts. A worrying sign are also the declining trends in availability of essential health and medical supplies, the challenges linked with the productive health workforce, and sometimes suboptimal leadership to drive accountability. The national health financing still is suboptimal, and budget trend analyses have shown still a dependency on and reliance on external resources in certain areas. Uganda also unfortunately ranks first in alcohol consumption on the African continent, with statistics showing alcohol consumption starting at the age of 15. So these challenges, if left unattended, hold the potential to reverse the hard-earned gains made in the health sector and jeopardize our efforts. As we celebrate the success in maternal and child care, it is incumbent upon us to redirect our focus and resources toward combating these pressing issues. As development partners, we would like to highlight 4 key areas that we think, if well addressed, will contribute to an improved performance of the health sector. First, we should work collectively to address the persisting challenges linked with the performance of health workers. We have seen that despite the recent salary enhancements, we continue to observe the absenteeism, the suboptimal performance, which affects the quality and quantity of a health service provided. As development partners, we remain committed to support the performance management initiatives to make the health workforce more accountable and optimally functional. Further efforts should be invested also to advance the recruitment initiatives aimed at achieving the maximum utilization of the wage bill provided by the Ministry of Finance, which will inevitably contribute to enhanced performance. Innovative solutions also should be looked at vis-à-vis the infrastructure improvements. Second, and here I'm quoting, health begins with households and communities. Therefore, indeed, it is crucial to accelerate the implementation of the National Community Health Strategy, promising swift gains across multiple domains. Key to curbing the rising rate of teenage pregnancy is the use of the National Community Health Strategy to disseminate in easily comprehensible local languages social and behavior change messages underlining the socioeconomic and health risks associated with unprepared parenthood. Similarly, implementing community-based approaches to enhance early childhood development, ensuring consistent school attendance for both girls and boys, adapting best practices for malaria prevention, strengthening the supply chain and its financing, advocating for healthy diets, improved food environment, and WASH, all those are vital in addressing the community well-being. These actions not only bring immediate benefits, but also empower communities to demand accountability from authorities and take greater responsibility for their health. Community-level multi-sectoral approach is the foundational and indeed most critical layer in engaging all sectors contributing to social determinants of health, and subnational coordination here is key. Third, it is of paramount importance to continue efforts in reaping the benefits of Uganda's demographic dividend. While commendable actions were made to reduce the unmet demand for family planning, it is also very important to continue to improve the accessibility to family planning resources for the 40% of the population whose family planning requirements remain unaddressed. Augmenting the involvement of men in the family planning program is also an indispensable component of such actions. Family planning initiatives, together with the comprehensive effort in the education, production, and livelihood sectors, will ensure the availability of the qualified and healthy human capital required to advance the economic and social transformation in Uganda. And in conclusion, we would collectively work to establish sustainable healthcare financing by enhancing and mobilizing the effective use of domestic resources, striving towards the ultimate goal of achieving universal health coverage. A significant step towards this goal will be the enactment of the National Health Insurance Bill in Parliament, and passing this bill into law is important. Concurrently, we also appeal to the Ministry of Health to explore the innovative strategies aimed at enhancing budgetary absorption and improving operational efficiency. Such measures indeed can ensure the effective allocation of resources to combat the prevailing challenges that we have discussed. Honorable Minister, host and guests, ladies and gentlemen, on behalf of the development partner, I would like to once again extend our really heartfelt congratulations to the Ministry of Health for this very successful joint review meeting, and we look forward to continue our collaboration to advance the health and well-being of Ugandan citizens. Thank you.
A big hand clap for the health development partners. To the Secretariat, I think really it's given you all the summary and even what we needed to do, so we really need to thank her for that. Before I invite the Minister, I want to thank Honorable Minister that the room is still full, though it's late. I want really to applaud the members all who are here. Lastly, Honorable Minister, I want to invite you to speak and officially close this 29th Joint Review Mission. I think it's better.
Don't be scared of these documents. Dr. Laro told me I have less than a minute. All the 15 minutes ended, and so I will keep to that. Allow me to skip protocol, but I recognize all of you in your various capacities. Allow me to start by introducing our honorable members of the Health Committee who have been with us here right from day one. I have our honorable member from Nakasongola, who is just there. Let's appreciate him for sitting through. And the one from Uganda who gave me my daughter, let's also appreciate him. Thank you very much for sitting through this joint review mission. Now I'm going to request all of you to turn to one another and appreciate yourselves for sitting through the 2 days with a smile. Very good, and I appreciate all of you. Thank you very much. Allow me to appreciate our partners who made it possible for us to be here and who have supported and participated in various activities. WHO, UNICEF, USAID, Uganda Health Systems Activity, and USAID, Uganda Health Activity, Embassy of Ireland, Embassy of Netherlands, and all the others. But allow me to stop there. Appreciate them. Next is my appreciation to you for your contributions to the discussions and also your contributions to the aid memoir that will input the next NDP4 and also our interventions for the next financial year. We are extremely, extremely grateful. That shows your passion for the health sector. Allow me also to congratulate those who have gone back home with accolades, including myself. Thank you very much. Lastly, I wish all of you safe journey back home, and may the good Lord protect you. It is now my honor and pleasure to declare the 29th Joint Review Mission officially closed. For God and my country. I hope I used 1 minute.
Yes, Honorable. You will get another hand clap for that. As the minister comes down, we started this meeting with a prayer, and also we are going to close it with a prayer. And as you know, the WHO definition of health is not just absence of disease, but all aspects of spiritual well-being. And that one will be done by Dr. Edith Naku, the executive director. Put her hand. Let's motivate our pastor to come.
Thank you, Dr. Laro. I'm very far from being a pastor. I'll try today. Dr. Laro suggests that I should say a word of prayer for the good of our mental health. And I would request that we please stand up for a word of prayer. Let's pray. Dear Lord, we thank you for this day. We thank you for bringing us this far and for bringing us to the conclusion of this 29th Health Sector Joint Review Mission. We thank you for the energy and wisdom you have given to all the leaders sitting here. We thank you for the progress and achievements that the health sector has made this far. We pray for further wisdom, energy, and a good spirit that as we leave, we should take seriously all the issues that have been raised here, including mental health. We pray that this may be mainstreamed into all the care we have talked about today. Grant us journey mercies as we go back, that we may reach safely to serve Ugandans yet again. In Jesus' name we pray. Amen.
Thank you, Edith.
Final announcement. The rapporteurs of the group discussions, please submit your scripts or your notes.